now says talking. You are using the computer audio. I want someone to talk, talking Professor Seganem Sisi.
Welcome, Professor.
Good morning.
Welcome, Professor Peter. This is
Hi.
Hi, dears. How are you?
Fine, thanks. How are you?
Yes.
Welcome on the call.
Yeah, but I don't see the faces.
Because they were disabled by the host.
Yes.
Oh, okay.
Actually, it's what I wanted to brief you, because when we have the faces, video slows the call.
Okay.
So we decided to not to have the faces so that the call can be better and swifter.
Okay.
Of course, for many of our panel of the participants, would want to see, make it personal, put a face to a name.
Okay.
But the hosts are going to come on. We're going to have the conversations before the participants join us.
Right.
So we're waiting for the others to come on board.
So I'm the first, eh?
You and Professor Waiswa.
That tells you something about medical doctors. Okay.
You're the most wanted item now, eh? In this corona world.
Corona world, eh?
Hey.
Interesting.
Hey, interesting times. Very interesting.
Very interesting times. Very tough times.
Very tough.
100 years it happened ago. They never had this technology. You can imagine how they survived.
Oh my God. That's why there was so much death with that Spanish flu. Because
Yeah.
also information,
Yes.
some of the preventive, but also knowing that things can be okay. That only just kills you when you know.
Yeah, but
and remember, it was during the World Wars also.
First World War, yes.
Yeah.
So it's problematic, but you know, but this one, we knew in medicine, we knew it was coming.
Oh, really?
And people were warned, and countries like the US were supposed to be prepared. In fact, they were prepared, but you know, Trump don't say this maybe, but everybody knows it. Trump.
There's no leadership from the US.
Trump,
but
no,
it seems
Trump, you know, like, you know, the Obama things, and he disbanded all of the things, including the books, and he threw them away. And when the thing came, they panicked, you know, and everybody's telling him that, and they all know it. So it's a very sad story.
Yeah.
Yes.
It seems that for us, it has been warning us. And
for us in developing countries,
we've been getting doses of preparation.
Yeah, yeah. I think for us in developing countries, it's time to learn to begin to be self-reliant. You know, China dealt with it. South Korea dealt with it. All those, you know, countries, except these ones which don't, you know, which have little problems.
No, these ones, they have too much democracy.
What does that mean?
No, actually, too much capitalism. Because Germany is democratic, but they did very well. But these ones, where they don't want anything to infringe on anybody's right whatsoever, you know, that's the problem. You know, say, who are you to tell me? You know, whether you know or not, they don't want to believe you. That's a problem we are having in the States right now.
Yeah, I mean, China closed down without consulting anybody. So,
yes.
And Museveni is also doing it here. A little bit of, you know, consultation, but, you know.
You consult with science, and then you bring in the law, as long as you don't infringe on people's rights, or not too much anyway. But you explain, because an emergency is an emergency.
Hi, Sarah.
Hi.
How are you?
Fine, how are you?
Yeah.
Hello, Sarah. Welcome on the call.
You.
We're waiting for Professor Ben and Rose, and then we can start. So now we are catching up with each other, how we are doing, how we are settling in, how important now it is to be a medical doctor, and how we need to be positioned.
Finally.
We're going to medical school.
Real doctors, right?
I tell you, people fear to go to medical school, you know.
We're going to run very fast.
The rescue mentality is always there in people's minds, so they'll come.
And then also we're analyzing the global politics, what it means, how prepared we are as countries, the challenges of the state, healthcare systems, etc. We are really having a general chat as we're
But
waiting.
people say that these pandemics change world politics. You know, like you see, after that First and Second World War, Britain lost power, as an, you know, the US took over completely. And people say that this one may be the defining characteristic, that China takes over as the leading world power. We don't know.
It's possible, because the US actually has not shown leadership. The US is at a
determination.
They are not looking at anybody else. They are so inward looking now.
No, they are saving the world. Can you imagine all of these PPE? You know, it's all coming from China.
Yeah.
America is buying from China. The whole of Europe is buying it from China. You know?
Except Magufuli.
Magufuli has a problem. I think he's a bit narcissistic, but you know,
Thank you for writing such powerful papers. I've read and read and read, and it was so exciting. You all looked at this from your own angle, but the conclusion or the end of it all kind of comes together so nicely.
Yeah. But to me, I don't see an end to this until we have a vaccine.
Yeah, of course.
Because I don't think this antiretrovirals it's going to be like AIDS. They will not remove the virus. We don't really have drugs, you know, that cure viruses, like antibiotics for bacteria. And it takes time to develop those. But a vaccine can prevent.
And people were upset. I think a video was trending. I think it was Dr. Bessie saying, all of us will get corona. And people were so upset. And I'm saying the flu viruses. People are so upset. They say,
is how we are going to live in the world with the corona.
Yeah.
You know, because now I fear to travel to Europe. I don't want to go there. I don't want to go to America. I don't want to board planes anywhere. You know.
Yeah.
And then you say, what about your people who are abroad? How, you know, to come back, they have to go into quarantines. You know, every country you go to, you first go into quarantine. Can you imagine?
Yeah, that is the new
world. If you go to Europe now, you have to go in a quarantine for 14 days. And then people get stuck, like people who are in transit. Can you imagine? I saw a doctor on news yesterday, Ugandan doctor stuck in Ethiopia. He was supposed to fly back, and then they banned all travel. How will he come back? He has a family here. Hello?
Hello. Professor Ben, welcome.
Professor Ben is here.
I can see him, but his microphone is not on or not muted.
I think he joined via video. If you can tell him to join via audio, then it will show.
He'll be joining us shortly. It's still connecting.
None of us is on video. The host held all of us hostage.
Apologies. It's for network issues.
Appreciate. So can we get Baguma and the others on the call? Because I'm worried we have only 15 minutes. and we have a huge number of participants.
Yeah.
So they're dying to get on the call.
Well, let them come on.
Professor Ben, you're welcome.
You're saying you're welcome.
Hello, how are you?
Ah, there he comes.
Great.
Hi, Ben.
Yeah, how are you, Professor Segane?
I'm fine. How are you doing?
I'm fine.
Locked up or locked down?
Huh?
Are you locked down?
No, I'm out of my 10 kilometers walking. Yeah.
Yeah.
That one I have to risk. Can't do much.
Yeah.
Professor
So
Ben,
we
you're
are.
welcome.
Oh, thank you, sir.
I mean, Professor Ben, you can't be locked down.
Huh?
Good morning.
Good morning, how are you?
Good morning, Peter.
I
Oh,
think
Peter, how are you, Professor Peter?
I'm good. How are you? I was saying that I think you can't be locked down.
No, I have to get out and do my exercise.
Good.
Yeah, I've done
You're
that
allowed
for...
to go in the compound.
No. I go out.
You go out to walk.
Oh, yes, I do that ever since the lockdown started.
Keep your distance, though.
Of course, I have to keep the distance and leave everything to God. I know you, Segane, you don't believe so much in God.
Well,
I know you don't believe in God. You are, but even
people say he brought this.
But even atheists, when they are about to die, they say, "My God."
Well, there are words people say, but and then there is what is inside.
What's
Yes,
important is really the works, what somebody does.
Yes.
Yeah,
but this is a wake-up call for humanity.
Oh, yeah. It is. But you see what's happening in Tanzania now, where the man is now bungling up scientific evidence, disputing it, talking
and
about
he does
talking about testing purples, testing mangoes. It's terrible.
You have to have some kind of, this is what I keep saying, the education system that we should always have has to expose us both to science and non-science to appreciate life.
Having a problem hearing.
But he's a scientist.
Scientists should understand humanities.
He's a PhD in chemistry. He has a PhD in chemistry.
Humanities should understand science.
Yeah.
Yes.
It's very unfortunate.
You have to have both.
Yeah.
Yeah.
Hey, Rose, welcome on the call. Can you hear us?
I can hear you, very well.
We cannot hear some people.
You can't hear me?
Yes, I can hear you very well.
Some people are not being heard.
Professor Sally.
Yes, please.
Are you on?
I'm on, but I'm here listening, and some people are stretching. I hope when we begin the call that will not be there. People need to check their network connections.
Maybe some microphones are not. When we start, maybe when somebody is speaking, it's not a microphone.
Professor Ben, it's not the microphone, it's the speed of the network a member is on. If you put low band or networks such as MTN, you're going to struggle in this 1 hour process.
Okay. So who can't you hear very well so that we sidebar them?
Well, we have to use the technology we have.
Okay. So I think we are now all on the call.
Okay.
You're welcome.
Thank you.
And I wish you'd seen me on my video. I'm so excited, but don't worry. Just visualize that I'm so excited. Yes. The power of imagination, that I'm so excited that finally we are here. Yeah. And of course, to congratulate all of you for really having put your thoughts on paper. We've attended many webinars where you do not know where the agenda begins and where it ends. But the fact that you authored technical briefing papers is very important because it stretches our imagination. And I know many of the participants can't wait to be part of this webinar. To allay our fears about participation, I know when I talked to you on Friday, some of you were saying the number that we had booked for 100 was small. I wish to inform you that we expanded our bandwidth and booked for a webinar of 500 people. As we are speaking, our channel people are registering like no man's business. So we are having a huge listenership, which some of this will be on the webinar, others are on other platforms. And I'll invite the host to give us a briefing in terms of how we are going to manage ourselves, why we are not having video, and then also how we are going to manage the time. I sent you a run-off show for us to be able to manage the time, but also to give you time for you to share what you so ably sat and wrote down. So I'd like to invite Grace, the host, to give us a briefing in terms of, first of all, we allowed you to talk so that we can test that your technology is working. And I'm happy that most of our technologies are working. We can hear all of you very well. But when there are issues like with technology, like we all know, we'll try to see how we backstop that. So Grace and Baguma, over to you, and then I can pass us through if there's any questions to the run-up show.
All right. Thank you, Salome. My name is Grace Kenganzi. I'm the comms manager at SEHAD, and I'm happy that you're all here. So I'm going to just do a quick technical brief. So all our videos are off so that we have a seamless connection during the webinar. And then during the webinar, I'll ask us, if you're the one speaking, please mute your mic so that we don't get any feedback from your background. And then if you have any a radio or a Bluetooth speaker next to you, but it's also switched on and that you're not using, I'll ask us to also switch it off because it can have, it can create feedback. So when you're speaking, sometimes we will hear feedback when you're speaking if you have such devices next to you. And then of course, I'll ask us to also put any other devices in our background on either silent, so that when you're speaking again, we don't get that feedback. And then during the webinar, there's, if you notice on your menu where there's mute, participants, Q&A, there's a Q&A section where participants will be asking questions. So you're encouraged, if you say a question that you can answer straight away without having to wait for the session, because we're expecting several questions, which we may not be able to go through during the session. You're encouraged to also to answer them immediately. Like you don't have to wait for the Q&A session, so that as many questions as possible are answered. The moderator will highlight the most outstanding questions, of course, even when you have answered them, so that the participants can see that. So yeah, you're encouraged to take part to use the Q&A part. Then during the session, participants will also be chatting, either commenting about what you're saying. So after you've spoken, you can go and check out what they're saying. If you want to, if someone is asking for clarification, you can reply them. And then when some people will raise their hands during the session, but since our program shows that the Q&A session will be at the end, I think the moderator will keep reminding them that we have the session at the end. Yes, that is it from me, really. It's just a reminder for us to mute our mics when we're not using them. And then, of course, when it's your turn to speak, please don't forget to unmute so that we hear you. Yes, that is it. That is all from me. Thanks, Salome.
Okay, thank you very much, Grace. Do we have any questions or where we need to seek clarity from Grace's brief? Silence means what?
I have a question. I have a question.
Yes.
How do you mute and unmute the mic? I'm not seeing it here.
Are you using your computer or your phone?
I'm using my computer.
So if you hover your mouse to the bottom, the menu should pop up. Has it popped up?
Oh yes, I'm seeing.
Yes, it keeps when the mouse after some time it disappears a bit, but you can hover at the bottom of it will come up. It has mute, start video, participants, Q&A, chat. Yeah.
Okay, thank you so much. I've seen it.
And then does any of you have any, if any of you has something you want to project also during the session, I can share my email address. Then we share it, but I don't think anyone has anything like that. But just in case.
Okay, and Grace, try to make sure there's sound that comes from your background that is like a constant sound. Try to make sure that it's not there because you're the host. And then when we start when participants join us, I'll give you a minute to give the housekeeping, just like you've told us what people expect, so that they don't complain about not having video or when they want to speak, so that we sort out the housekeeping stuff. I hope that is okay with you.
Yes, that's fine. About the background noise, I don't know where it's coming from because I'm in a very quiet place. So I don't know if it's the wind, and I apologize for that. The good thing is I'll only speak at the beginning. After that, my mic will be muted the whole time. But that's fine. I will give that debrief.
Okay, thank you very much. So my very honored panel, keynote speaker and the panelists, I sent you a run of show to help us know what starts when. Apologies for sending it on Labor Day and making you work on Labor Day. And I know I called some of you on Labor Day. However, we are in a new world where probably things are changing. And also wanted you to prepare your thought process before now. I wouldn't pass through the whole of it, but if there's anybody that has any questions, it was really showing what we're going to do and then how much time you're each allocated. We have a very engaging next 2 hours from 11 o'clock to 1 o'clock. You're all highly accomplished people. You've invested enormous energy, time, intellect, and priority to your papers. But we would like to appreciate and acknowledge that time is something we can't control. So as much as possible, if we work within the time, it gives us 30 minutes to engage with people because already questions have come in. And on my part, I've been sent questions already when the advert was sent out. Some of those I'll send in your inboxes in WhatsApp so that you can know what kind of questions some people are asking that are related to the topic that we're going to discuss. Do we have any comments, questions on the run of show?
Just one little question that I have. You said that when it comes to question and answer time, that you click on this Q&A, or it will just come on automatically?
What I meant is during the session,
yes,
that Q&A part, people already posting questions. So
yes.
if you see a question, you will be able to view the questions during the session. If you see a question that you can answer already, even before the Q&A session, you can go ahead and type the answer. Because either way, during the Q&A session, the moderator will be reading from this section. So it's active already. As soon as we broadcast, it will also still be active.
Okay.
And then I know there are many enthusiastic webinar participants. Some of these will start posting questions even before you speak in the Q&A and the chat. For the Q&A, you can answer immediately because you can click on it and answer. And then for the chat, as much as possible, we'll try to look at it, especially when you're not presenting. And on my part, I'll also look at it to make sure that particular questions are extracted. And if you've not responded to them in your presentations, I side by you in your WhatsApp. And then if you have the time, you can respond to them in the Q&A session when they were responding.
Are you going to send on what? Did you say WhatsApp or in the chat?
I would like to send you on WhatsApp because this chat from 11 o'clock it's going to have us, the 10 of us from Sehan, and then 500 other people. So we do not want them to be part of our conversations. If there's a question that probably has passed your eyes, I'll send that to you one-on-one in WhatsApp from my WhatsApp phone, your WhatsApp, to alert you to say there's this question that has come in case you've not seen it, to help you moderate, but also to help you focus in case you're the person presenting at that time.
Okay.
So we have 2 minutes to people joining us. Anything that you'd like to share? We might even want to share how we are coping.
Madam Moderator, this is Mulumba Moses, just to say thank you all for making it, and we very much look forward to the conversations.
Thank you.
Thank you.
Thank you, Moses, and thank you for organizing as Sehad and providing the platform to have this conversation. Baguma, we've not heard from you. You're conspicuously quiet.
Yeah, Salome, thank you very much. I know I'm quiet for now because I've had various communications and engagement with the panelists. And by this time, we've been set. And I think we need to get the ball rolling. It's time most of the precautions and guidelines have been given by Grace. And I know they are ready now to give us what they prepared in this time that we've been engaging with them. It's almost 3 or 4 weeks now. Yeah, I wish you the best, and I know people are yearning for this, and it's time now for the session to begin. Thank you, Salome.
Thank you too, Baguma. And now that we know all our microphones are working and we are all on the call.
Okay, I am broadcasting now.
I don't see any faces.
Hello?
Welcome to the webinar on the right to health during the COVID-19 response in Uganda. And we're going to have a deeper discussion today on the implications of the national response. I am Salome Nakawesi. I am your moderator for the next 2 hours. And I am honored to moderate a panel of accomplished Ugandans, Africans, and international human rights activists and medical practitioners. On my panel today, we have a keynote speaker who is none other than Professor Ben Binomugisha from the School of Law, Makerere University. And for those of us that would like to know more about Professor Ben, he's going to tell us who he is in a minute after I do the introductory session. Then we have a panel of 4 people. And we have Rose Wachikona from the Center of Health, Human Rights and Development, CEHAD. We have Professor Peter Waiswa from the School of Public Health, Makerere University. We have Professor Sarah Sali from the School of Women and Gender Studies, Makerere University. And lastly, Professor Segane Musisi from the Department of Psychiatry, School of Medicine, Makerere University. This panel is going to enable us look at a cross range of issues. From one point, we're going to really look at the response and the realization on the right of health. And Professor Ben is going to take us through that. And then Rose from the CEHAD is going to enable us really look at safeguarding the rights of frontline health care workers, because they're at the center of managing this crisis. And like we all know at this point in time, we realize how important our healthcare providers are nationally, regionally, and internationally. And then Professor Waiswa is going to enable us deconstruct and look at reproductive health, maternal health, newborn, child health, and adolescent health. Because like we all know, health issues still continue amidst this pandemic that are beyond COVID-19. Professor Sarah Sali is going to look at the gender dynamics of COVID-19. Anything in life has a gender lens, and we're going to have the conversations there. And lastly, Professor Segane is going to enable us to look at COVID-19 and the impact on mental health. Thereafter, I know we'll be warm enough to get into a question and answer session. And after that, we're going to summarize. And due to time, we're going to close this webinar. And then we'll direct you to where you can get further information, because this webinar has been organized in a way where we have a total of 5 technical briefing papers that the panelists have prepared. But before we get into that, I'd like to invite the hosts to tell us the housekeeping rules, what will enable us to enjoy this webinar, but also how do we manage ourselves, because there's so many of us and you're in different time zones, as well as different locations across the continent and across the globe. Welcome on board, and we look forward to having a great time with you. Grace, please tell us the housekeeping rules.
Thank you, Salome. Welcome, everyone. We are honored to have you here. So a few housekeeping rules. You'll notice all your mics and video are off. That is so that we don't have any interruptions during the session. During the Q&A session, we will raise our hands, and when the moderator picks on you, your mic will be unmuted. You will receive a prompt asking you to accept that your mic should be unmuted. Please accept. If you don't accept, then we will not be able to hear you. Please also take advantage of the Q&A section, which is in the same place where your mute, start video, and chat section is. You can start asking your questions even as the panelists are presenting. In case you get disconnected from Zoom, we are also live streaming the session on the Center for Health, Human Rights and Development Facebook page. So you can join us there if Zoom is disturbing you. We shall also be taking your questions on that Facebook page. Otherwise, we hope you will enjoy the session and that it will be productive for you.
Thank you very much, Grace. I'd like now to take an opportunity to invite Professor Ben Binomugisha to tell us who he is and what he does.
Thank you, Salome. You hear me?
Yes, we can hear you loud and clear.
Oh, very good. Thank you so much, my colleagues and the organizers. I am Ben Trinomgisha. I teach law at Makerere University, and I also assist in some kind of work with SEHUD. I'm glad to be here in the chat room. Thank you.
Thank you very much, Professor Ben. And Professor Ben is going to be our keynote speaker, but before he starts the keynote speech, I'd like to invite the panelists to introduce who they are and what they do. We'll start with Rose.
Good morning, everyone. Yeah, my name is Rose Wachkona. I am a senior program officer with the Center for Health, Human Rights and Development, which is also SEHAD, and I'm very glad to be here. I work with the Strategic Litigation Program.
Welcome, Rose. Professor Waiswa.
Good morning, everybody. My name is Peter Waiswa. I'm an associate professor at Makerere University, School of Public Health, College of Health Sciences, and I run actually maternal newborn child center of excellence. Recently, I was honored to be actually appointed by the Director General of WHO to be one of the advisors on reproductive maternal newborn child health, including these issues of COVID. Thank you.
Thank you, Professor. Now go to Professor Sarah.
Good morning, everyone.
Good morning.
I'm Sarah Sally. I'm an associate professor of gender studies. I am the dean of the School of Women and Gender Studies in Makerere University, and also the director the Center of Excellence in Notions of Identity, which belongs to the African Research Universities Alliance. Thank you.
Okay, thank you. Lastly, Professor Segane. Professor Segane, are you there?
Have you heard what I said?
No, we've not heard.
I say that I'm Professor Segane Musisi, Professor of Psychiatry at Makerere University, School of Medicine, College of Health Sciences. Do you hear me now?
Yes, very clearly. You're welcome, Professor Segane.
Thank you.
And I'd like to welcome our participants. I know there's so many webinars that are happening at the moment. I know there's so much that is happening, but the fact that you've joined us shows how committed you are, how interested you are, but also how far you're looking for if there are any answers to some of the questions that you have. And today, our webinar is going to assess the impact of the COVID-19 national response on the realization on the right to health in Uganda, and also suggest mitigating measures. It has been organized by the Joint Advocacy Program on SRHR that they call JAS Programme, which is a partnership of 7 organizations working at the national and regional level. Akina Mama wa Africa, Human Rights Awareness and Promotion Forum, the Coalition of Health Promotion and Social Development, HEPS, the National Forum of People Living with HIV and AIDS, Networks in Uganda, NAFOPANU, Reach a Hand Uganda, RAHU, Uganda Network of Sex Work-Led Organizations, UNESCO, and the Center for Health, Human Rights, and Development, SEHAD. And this program is really aimed at garnering collective effort on sexual and reproductive health and rights, movement building and organizing in Uganda, and is funded by SIDA. I'd like to thank the conveners of this particular webinar, as well as the partner CEDA who is supporting the webinar. So at this point in time, we are dying and ready to get into the gist of the conversation. Professor Ben, please start us off with your keynote on the response and the realization of the right to health. You're welcome to this. Professor Ben, are you there?
Do you hear me now?
Yes, we can hear you now.
I'm sorry, I had not unmuted my microphone. I'm very sorry. So I was saying that the topic of my presentation today is COVID-19 response and the realization of the right to health in Uganda. As we know, COVID-19 is a topical issue. And I observe that it's a public health, gender, human rights issue. And when I talk about public health, I even include questions of mental health. And I'm glad the panelists, Professor Segane, Professor Waiswa, and Professor Sali, joined by Wachkona on health workers, are going to touch upon these issues. So the presentation tries to address three important questions. What are implications of COVID-19 response to the right to health in Uganda? Second, how should government of Uganda ensure that COVID-19 response does not undermine the realization of the right to health? And thirdly, what role should civil society organizations play in the struggle to realize the right to health amidst the COVID-19 response? The paper or the brief is a bit detailed. It has a section that tries to tease out the normative content and scope of the right to health at the international, regional, and domestic levels in our constitution. I will not go so much into that detail, but suffice to note that Uganda is a party to international, regional, human rights instruments that recognize the right, and that the Ugandan constitution also has provisions with a strong bearing on this right. And these instruments also point to the obligations of Uganda. And in addition to the international human rights that we are used to, the WHO in 2005 developed international health guidelines on epidemics, pandemics, endemics, etc., which within the public health and human rights realms, we refer to those regulations. And the second point here is that these instruments move beyond healthcare as a right, and they also encompass social determinants of health, issues like environmental matters, gender, poverty, and others that implicate the right to health. So with that brief presentation on the right to health, I go into what the obligations of government are, and basically they are to respect, protect, and fulfill the right. For the non-lawyers, but this is also very critical, there's what we call an obligation to progressively realize the right to health according to the available resources for a particular country. But within this right to health arrangement, there are a number of obligations which we call core. That is, they are so important that even in a state of emergency, a government should ensure that minimum levels of these, of the right to health are realized. And these include the right of access to healthcare services and goods, commodities, access to minimum essential food. You know, been hearing about people who are moving to healthcare centers during curfew and they are stopped on the way. Essential food, that's why government is coming in. Basic shelter, essential drugs, maternal and child care. You've been hearing of women who are in labor in urgent need of care, and some of at times whose labor is obstructed and they need emergency obstetric care, and at times they don't have permits and they have to move. So we are saying these type of rights are so critical, and especially for the vulnerable and the poor, that whether day or night, these rights must be realized. The question of labor and delivery care does not know class. The woman who is into that, even the one who has, for example, an ectopic pregnancy, they need that type of emergency care. And another key core obligation is to take measures to prevent, treat, and control epidemic or endemic or pandemic cases, as we have COVID-19, as I indicated in the brief. The WHO recognized it or declared it as a pandemic. Quickly move to the implications of government response. And we know the response. I will not go into detail. It's in the brief. Quarantine. I used to call it quarantine, like using a Ruchiga word, but I've heard from the Minister of Health it is pronounced as quarantine. Quarantine and isolation, lockdown, including curfew. We are living this. We are part of it. I will not go into detail, but when you go the brief, you'll see what the WHO has elucidated on what these concepts mean in the context of tackling the pandemic. So the COVID response point I have to make first is that on this response, indeed, government has done its best. And in the brief, I say the response was designed and implemented in good faith. And government is trying to do its best. The president, the minister of health, and her technical team, the prime minister, they are trying to do their best. But inevitably, through what we call the public health and human rights framework, where public health and human rights are supposed to be mutually reinforcing and complementary, you'll find that certain measures taken within the realm of public health inevitably impact on human rights adversely or in a negative fashion. And that one we are going to see later. So what should government do? My first observation is that we need to understand the normative scope, or what we call limitation of rights. Our constitution was shaped in such a way that Chapter 4 outlines rights and freedoms which the government, agencies, and even private persons are supposed to observe, including the right to life, even right to health in some of the provisions in the objectives of the Constitution. But these rights under Article 43 of our Constitution, building on the United Nations Saracusa principles on restriction of rights, these rights can be limited. These rights, including the right to health, including assembly, association, worship, movement, can be limited on two grounds: one, for the protection of public health, and secondly, for protection of the rights of others. And protection of public health is what the state is doing now to protect us from this pandemic. But I'm saying in doing this, government would ensure that they observe those conditions which I put forward in the paper, to ensure that they do not burden the rights in a disproportionate manner. Secondly, government should ensure that the core obligations which I have listed above, in terms of the right to health, including access to essential emergency health care and nutrition, people shouldn't starve. They should ensure that those obligations are met. Government, I say, should mobilize and deploy resources, both internally and externally, whether it is financial, physical, or even human resource. And this is very critical. Later, I'll talk about the protection of health workers to ensure that they are motivated, they have protective gear, and they have working equipment. Government should ensure participation of of the citizens, including health workers, into this response. It should take steps to combat stigma and discrimination against the patients, whether within the quarantine places, isolation centers, or when they are discharged and released to the communities, because stigma and discrimination can be very challenging. And I'm even saying they should continue to ensure periodic review of the response, and I'm happy the government is doing that, so that you see whether it is 2-3 weeks, then the government should come up and say, is it time now to lift, basing on scientific evidence, not through pressure, and not through unscientific means like what we are hearing from Tanzania. Observe ethics, here I talk about 2 things, questions of data protection. We have a law now on data protection and confidentiality, and the international health regulations emphasize this. Support, I think I said, and I protect health workers, and the brief I emphasized in the full scale paper, but that one was cut out in the brief. These people also have children, they have families. When they are in the workplaces, quarantined there, they are also quarantined. I'm using it in quotation marks because they are not allowed to move out, most of them. Then their family should be taken care of.
Professor Ben, we can't hear you. Professor, are you there? Professor, are you there? It seems we've lost Professor Ben. Give us a minute or so to get him back on. Professor, are you there?
I think we lost him. Maybe we can continue with others, then he can come back.
Okay. So what we can do is to beg your indulgence as the webinar participants and attendees, and those that are streaming on our various social media platforms. The professor will get back on, and we'll get back on. But in the meantime, I'll ask Ross to step in and share with us about frontline healthcare providers. And then Professor will get back on.
Thank you so much, Salome. I am very happy to be here to present on a technical brief that we developed at our strategic litigation team. The paper was specifically looking at the rights of people front line of the fight. Again, another thing for us to take all measures possible in order to protect them against any risk that may come from them working at the front line. So we all know that health workers are at the front line of the fight against COVID-19, but have been elected of prioritization for information on how to combat COVID-19, but also in the procurement of
We can't hear you clearly.
equipment.
Hello?
Yes.
The things that are
Alan. Can I request Rose to get off now? But we can't hear you. Rose, can you please get off the unmute? Okay, are we doing good now? Professor, are you back? Rose's network is also a bit jumpy. Professor, if you're back, Professor Ben, can we continue with your presentation as we are sorting out Rose's network?
Hello?
Yes, we can hear you loud and clear.
You can hear me now?
Yes, sorry we lost you.
No, there was a challenge. You can hear me. I don't know even how far I was talking, thinking that you are following. I don't know even how far I had gone. Whether you were following me.
Yes, Prof.
Can I try to bring you on board?
Yes, sure, please.
Did you hear when I was talking about limitation of rights, seeing that it's allowed?
Yes. Yes, that is where you stopped. When you stopped where you're starting limitation of rights, yes.
Yes, when I say limitation of rights are permissible. Hello?
Yes, that's where you stopped.
Okay. And then I was saying that the government response to COVID-19 is permitted by the Constitution, which allows the limitation of rights, including the right to health, on grounds of protection of public interest, including public health, and safeguarding the rights of others. And I was saying that the obligations which I talked about, like ensuring access to medicines, ensuring that people have access to health care, including emergency care, are provided. And I was saying government should mobilize both local and international resources in this era of the response, insofar as realizing some of these components of right are concerned. And I said government should also ensure participation of citizens, including health workers and all affected people in this response, and should ensure free flow of information, ensure that the information that is provided is scientific, based on scientific evidence, based on research, and they should not cook up any information, and I believe they are doing it well now. And steps should be taken to combat stigma and discrimination, including during within the quarantine and isolation places, or even after these people have been discharged, when they go to the communities, so they are not discriminated against. And should also ensure, I want to see it together. Hello? Hello?
We can hear you.
We can hear you.
Okay.
We can hear you.
I'm sorry, I have to continue. Okay. Then the government should ensure a periodical review of the response, because this response must not be there for forever. But I'm saying the review should be based on scientific evidence so that we do not have to rely on conjecture and just guesswork like we are seeing in Tanzania, where I suspect, I'm sorry to say this, that there is some kind of manipulation of data and even intimidation of laboratory human resources. So the data that should be released should be able to inform the periodic review response, and I'm happy the government is periodically informing us of this. We need to observe ethics. Government should need to observe ethics. Minister of Health in terms of data and confidentiality, because we have a data protection law, ethical requirements on confidentiality, support, and even this question of ethics should, when we come to vaccines, when they come to trials or even drugs, the ethics of research as per the National Council of Science and Technology guidelines on researching on human subjects, they should ensure that the institutional review ethics committees handle this question. Then government should not politicize the fight against the pandemic. We should ensure that all of us are in it, whether political parties, religious leaders, pressure groups. And I was happy when the president welcomed the donation from the Bobby Wine pressure group, although tongue in cheek. But we should ensure that there is partnership between government and other key stakeholders, including civil society organizations, in handling this. So they actively involve the private sector in the fight, and I'm happy about the donations that are coming up, but we should ensure that these resources are utilized for the purpose of responding to the COVID-19, including provision of food. Although I saw what Kiza Besige posted, I think there is also need pub messages touching the nutritional aspect of the response, what people should eat to boost their immunity in terms of ages, including the elderly, etc. Hold all agencies involved in the COVID-19 accountable, especially where human rights are violated beyond what is acceptable by our constitution. We have heard of cases of torture, cases of people denied care even when evidently someone, for example, is seen as pregnant or very sick. So the state of emergency, people have been debating that maybe the government should declare a state of emergency under Article 46 and 110 of the Constitution. My view is that the state of emergency, given our fragile democracy, should be the last resort, because you are likely to have gross violations of rights when there's that kind of state emergency and people may not be held accountable. I rush now to the role of the civil society organizations, and I expect a lot of contribution from this. I'd say, in my view, civil society organizations should not fiddle their thumbs, should not simply sit back and say, since there is a response, we should sit back. The first point of engagement would be to lobby and engage authorities to place civil society organizations in the category of essential services, so that they are issued, say, with special permits to essential staff, so that they are able to reach vulnerable individuals and communities. In the brief, I go into detail. Civil society organizations should be proactive and innovative. They should inform and consult the Ministry of Health on measures to be taken, and engage certain companies, private companies, or even individuals, company like Jumia, they deliver some essential products. For example, if you are delivering morphine, somebody, it's a cancer patient, terminally ill patient, someone has, you have heard from the grassroots or some place that somebody has had an unsafe abortion, maybe you want to assist in some way. So with some kind of post-abortion care, you want to send some antibiotics somewhere. How can you handle that? We need to be innovative. Then jointly cooperate to look out for emergency cases. You can have organizations cooperating both at the macro and micro level, the grassroots, and document violations of rights during this period, so that after COVID, we can take steps, whether through litigation or other means, for purpose of holding whether they are government or non-governmental actors accountable for violations. Then hold virtual meetings as we are doing. I think that is clear. And ladies and gentlemen, by way of conclusion, I'm of the view that the COVID response can adversely affect human rights, including the right to health But what government is doing is a move in the right direction to protect public health, including key aspects of right health, and limitation of rights, including right health, are permissible, and the government should ensure that co-obligations, like that question of nutrition, essential service, essential medicines, maternal and child care, etc. Basic shelter, like for these street children, people who sleep outside, etc., should be maintained. I'm very sorry for the break that happened, but that's thank you very much.
Thank you very much, Professor. Hello?
Yeah, hello?
Thank you very much, Professor Ben, for tickling us and starting us off. Of course, the new world order in which we are living in, which we have to learn, is how to organize amidst the challenges of technology. So we'll try to be kinder to each other as we're trying to reconnect on the technology, because this is a time when most of us are organizing virtually now. You've raised pertinent issues that we're going to discuss as we're having the comments. I'd like to encourage the participants on this webinar. Please type your questions in the Q&A as well as in the chat room. And I also know those that are live on Facebook already typing. The questions are being sent to the respective panelists so that when we start responding, at least we have a very robust conversation. So we're going to move on to Professor Waiswa, because Rose is still trying to reconnect on the network. And Professor Waiswa is going to talk about reproductive health, maternal, newborn, child, and adolescent health. For the response, Professor Waiswa, you are welcome.
Thank you so much. I'm very happy to make my presentation. My presentation is going to be on sexual reproductive health and COVID-19 in Uganda, with the theme avoiding the pitfalls of unintended consequences for maternal, newborn, child, adolescent health and nutrition in the response. And in terms of the outline, I'll talk about the context. I'll give some WHO guidance. I'll also talk about the consequences of the control. Then I'll also talk about the government response and then give some recommendations. So in terms of the background, I want to start by actually applauding the leadership of Uganda, the government and the Minister of Health. You know already, I can't tell you more about COVID in Uganda because many of you live here and you know what has been happening in Uganda, but also elsewhere. Uganda has had, I think up to date, about 88 confirmed cases and no death. There are not many countries you can report that have had no death. And I think we've been a learning country in terms of diseases I call them diseases of fear, which also such diseases when they are of risk to men, to the powerful and to the economy, then everybody comes on board. So diseases like COVID-19, HIV, Marburg, Ebola, when the powerful and the men see themselves at risk, they've come together to actually make a response. But I want to get back to, we should not forget that other diseases continue. And these are the diseases of the vulnerable, those people who don't have a voice, babies, mothers, adolescents. And this is what I'm going to be speaking about. Now, we have COVID-19, but our normal health system continue. I call it normal health system, which is actually abnormal. And here is what I want to show you. So even before COVID, we have almost every day, almost 5,000 women who give birth every day in this country. We have about the children who die before 5 years, almost 200 children who die every day. So by the end of today, we shall have about 200 children dying in Uganda, maybe more because of COVID. And also those include neonates, about 80 neonates, and there's this category which is called stillbirth that nobody speaks about. And I call upon people to spend more time on stillbirth. but also we have about 16 maternal deaths a day, and maybe more because of COVID. And then we have also this big problem of malnutrition. We have HIV, AIDS, and the other issues. So our normal health system, even without COVID, is not normal. And we need to pay attention so that we continue providing these services and not just focus on COVID. What does WHO say? WHO says that countries should introduce a phased approach to pandemics, where you start with simple things like when they started by closing schools to total lockdown, depending on how severe the conditions are. Now, WHO also recommends that when countries are responding to pandemics like COVID, they must balance the demands of responding to COVID while simultaneously engaging in strategic planning, the word is strategic, and the coordinated action to maintain essential services so that we reduce the risks, we mitigate risks, and the system doesn't collapse. And this is my core that right from the word go, we needed to be doing that. What have we seen so far in the country? We know that because of the control measures, especially the lockdown, the control on transport, has had consequences. We know that we have had a ban on the use of motorized transport, both public and also private, and there has been a curfew. This has affected health workers. Many of our colleagues could not get to work, and many of us such have not been able to get to work. We needed stickers. A lot of people have not gotten them, and unfortunately, it is our people who are getting the stickers. Although health workers have been given, many have not. The beating up and harassment of health workers, the patients struggling to get to facilities. We've had mothers get ruptured uterus. We have had maternal deaths, neonatal deaths, child deaths. You remember a woman, a nurse was pushing a mother for more than 2 kilometers. There is also a struggle to transport medical commodities to health facilities. And essentially these things, although there has been improvement, they still continue. We've also seen that the patient numbers in hospitals have gone down. We wouldn't expect that COVID would reduce the number of patients. So where are these people? They are there in the community not getting medication because there are issues of transportation. There's actually panic and fear. Panic among the health workers, but also panic among the general population about COVID. Although there has been information, I call it a bit elitism. Most of the information in English mainly has been focusing on those who have a TV, a bit of radio, but how about communities? There's been a breakdown of the community health system in Uganda. I'm going to be coming back to the EGS teams as quite a backbone of our health system. And then one of the challenges has also been the personal protective equipment. This has been of limited supply because we're used to mainly importing these things. Now, the government of course has tried to respond, put in measures, provided stickers, put up a transport system, they've been distributing food, and there is the committee in the Ministry of Health on the continuity of services. But as I was said, these things have not been enough. So what are the recommendations? My recommendations are the government should actually have learned from the outbreaks we've had so far, many of them, and ensure that normal services have to continue. We need a systems approach where we make sure that the building blocks of the health system, as we know them, are already ensured, with communities at the center. Communities being at the center of the response. Professor Massa says health begins at home, and then it is fixed in the hospitals. So recommendation number 1, I think it is time we know that our most important sector in the country is actually the health sector. If we are not healthy, then we cannot have economic development. But the health system has not had adequate response. So we need to reaffirm primary care as the foundation of our system. With primary care, we mean that first place where you first go. usual at your home or in your community, must be strengthened. And of course, that also includes the district health systems must be strengthened. We need strong community systems with VXTs that are empowered. Now, we elected LCs, LC1, LC2s. What do they do in terms of health? They have never been oriented. They need to be brought on board, trained, and ensure that the health of their community is good. We need to equip and staff health facilities, especially those where people first go, the ones closest to them. We need to build on the COVID-19 control. Actually, it's been a good thing that things like cleanness, washing hands, the issue of upper respiratory tract infections, hygiene of the nose and stuff like that, clean hospitals, clean public places, affordability of issues like soap and sanitizers. These need to be routine. They shouldn't be just emphasized during COVID. So this should be an opportunity to ensure that we build on them. We need to strengthen districts. These are the foundation of our service delivery. But in this country, districts receive very little financing. The human resource is still limited, and most of the activities tend to focus at the center. Then transport. We need to ease transport for health workers. Why do I need a sticker when I have my uniform or when I have an ID? I should be able to move around just with my ID. Then if a patient is critically sick, why should you need to get permission? Diseases don't wait, emergencies don't wait. You can die within minutes. We need to operationalize our decentralized national referral and ambulance system. Because we have a new policy on ambulances and referral, but actually it's not functional. They've been trying to do this in Kampala. Is this a time really to operationalize the referral and ambulance system? Then the government and partners must ensure that issues of reproductive health, issues of health education, issues of access to information, this should be universal, should be accessible, should be in a simple language, and should be accessible even for younger people. So we should use various means. Right now, as I've said, most of the focus has been on what I call elitism. The government should ensure that all health facilities, including the public not-for-profit, our NGO and the private facilities are struggling. They depend on patients coming to them, but now patients are not going there. How are they going to pay their staff? We should call upon the government to ensure that they increase their support to these PNF facilities. Then we must, finally, when we are doing the COVID response, like Professor Ben said, we must ensure that there is research. It is based on evidence. It is data-driven. And we should strengthen our M&E and the R&D system, research and development. It is time for Uganda to become self-reliant. And finally, on the NGOs and CSOs, what is my call to you? I think I will build on what Professor Ben said. Continue advocacy so that our MNSH is attended to in real time. Continue providing services and educating the public. Continue mobilizing resources and also supporting the government to mobilize resources. The issue of accountability, we've talked a lot about the 10 billions, but is it only 10 billions? Advise governments, and finally, you should strengthen your coordination, alignment, and how you set your priorities. Because I think CSO work is not well coordinated in Kampala. In the conclusion, I think COVID is a wake-up call. We need to be self-reliant, and we need to put health at the center of our national development, and we need to be more prepared. Thank you so much.
Thank you very much, Professor Waiswa, for challenging us. And of course, they say whenever there is a global crisis, it's either an opportunity to change the way we've done things, it's an opportunity to challenge the dominant narratives, but also it is an opportunity for us to be able to do things differently. I hope it will allow all of us, governments, civil society, academia, media, to use this as a turning point to make a better world for all of us. So we'll now move on to the gender dynamics. I know we've seen a lot in the newspapers, we've seen a lot on TV, we've had a lot, but some of us have lived experiences because anything that happens has a gender dimension. Professor Sarah Sally is going to pass us through that so that we can really understand that we live in a gendered world and the response also has gender implications. Professor Sarah, you're welcome.
Thank you very much. Good morning, everybody, once again. Can people hear me?
Yes, we can hear you.
Yes, thank you very much, Salome. And thanks everybody for coming to our call. As you've heard, my presentation is around the gender dimension and the gender implications of COVID. I'm going to also address this by briefly giving an overview of what gender intersectionality is, because that is going to be the framework through which I'm going to look at these things. First and foremost, I would also like to share the views of my colleagues that the government did what it could do at the time. This was an emergency, and the response was of an emergency nature. And I would also like to share views, to share the sentiments of my colleagues with regard to health being a human right and all the issues they have raised. So if I'm to go to my presentation, I'll begin with a brief understanding of what gender is and how I've approached this, especially when I wrote my paper. Then I will proceed to look at the gender implications of the lockdown, and then I'll also give some recommendations. And in doing all this, I'm guided also by the different SDGs. I agree with all the policies my colleagues have mentioned, but also I'm guided by the different SDGs, and I will be addressing them one by one. Now, we all understand gender as the socially constructed differences between males and females, and that imposes on males and females different obligations. They are structural, they are historical, and having a crisis like COVID does not change that. But we also know that these gender differences are mediated by other parameters, such as class, such as race. Professor Waiso had just talked about elitism, such as language, such as location, religion, and we shall look at all that. So my approach is looking at gender in an intersectional manner to say what is going on here and how are different males and different females fared under this COVID lockdown. And for starters, we all know the international literature, the vulnerability to COVID has been gendered. Males are more likely to be sick from COVID, but also to die of COVID. But of course, when we left China and Italy and moved to the US and the UK, we realized that it is not just gender, but also the other parameters like the color of your skin, which part of the city you live in, and whether you're an immigrant or local. So there are all these parameters and the evidence is still coming in. So we don't yet know for sure how much we can hold and pin down to. But of course, some of the things are going to things which are behavioral, things which are historical and structural, in that people are born into poverty, and this ensures that they either have insurance or they do not have it, and etc. Now, coming back to Uganda, how does this help us to understand health and human rights in the COVID lockdown? We know that when COVID came, of course, it is a disease, and the major response has been of a medical nature. We've been treated to a number of talk shows by medical providers telling us how it is transmitted, what we should do to avoid this or to avoid the other. And even when the president speaks to us, most of the time is with information from medics. Professor Waiso has talked about the elitism, but I think beyond the elitism is the over-medicalization of this pandemic, because a lot of what the public health experts are talking about are behavioral in nature. Each epidemic that has hit Uganda, whether it is Ebola, whether it is cholera, whether it is whatever, the same things have been said. But how come we have to be reminded? How come they have not set in and become part of our routine existence? So when we look at gender dynamics, how did males and females or different males and females fare in this epidemic? The first thing we had, of course, we saw a number of females being appointed. We are still studying the impact of that. I think it has been wonderful. We appreciate that. The ministers and all the people largely in the COVID response seem to be females. But then we can also look at what does gender bring on board in terms of identities? What does being a male mean and what does a female mean? And therefore, what does the implication of locking down mean? Of course, one of the measures was to close down essential services. And food markets were allowed, health facilities were allowed, but the rest largely was like, keep away. But where do most of Ugandans get their bread and butter or their daily survival? 94% of Ugandans are in the informal sector, or they are in self-employment or small-scale entrepreneurship. So what did this mean for them? Of course, the big supermarkets were added, and we shall come to that later. But for those who are surviving on a day wage, some not cope, and until the full provision was provided, had to make their way into the shops. And we saw onto the street selling mangoes and the rest, and you saw the brutality that came with that. We, of course, have an SDG against hunger, and the SDG number 2 talks about zero hunger, and clearly says the hunger is the biggest, it kills most people in the world. It's the biggest killer of humanity world over. So while people appreciated the challenge of the illness, they were not going to stay home forever. So they came out, and of course they faced the brutality that they faced. But thank God, of course, later on there's relief provided. But this relief, as all of you who have been on social media know, has agendered. People are complaining about food not reaching them in time. And we've seen the demonstrations of women with their children and saucepans at the police stations. But while women are demonstrating for food, what does this do to the men who were previously providing, who were previously not associated with the domestic space? They left in the morning and came and now have to stay there. This produces a kind of mental stress on them. And could it explain the cases of domestic violence that we've seen? By the way, not just in Uganda, but world over, the domestic violence is excessive. So that is one of the aspects. The other aspect that we are talking about, that we've seen in this COVID-19, is access to healthcare, which other people have emphasized, so I'll not talk much about it, but probably just to add the dimension of no access to antenatal care. While government relaxed for pregnant women to be driven to hospitals to deliver, there is no relaxation on attending antenatal care. So what does this mean? Could it explain the ruptured uteruses and the mortality that Professor Waiswa spoke about? Education institutions were closed, and we were told that the people are going to learn online. And again, this is elitist. We teach our students online, but how about the majority of Ugandan kids who cannot be online? Recently, the Ministry of Education brought up an intervention of sending materials to the local communities. But we are yet to see how this is going to play out in terms of access. And also what we should remember is that in the domestic space, by kids being at home, this has different ramifications. If they are girl children, they are likely to engage more in domestic work because they're not going to sit there and read. If you're talking about a radio, who has access to the radio? Can these families access batteries so that they can listen? Because I know there are some classes which are being broadcast on radio. Then for boys, could this lead them into being in trouble because they are redundant? But also for the parents, in the elite homes where we are homeschooling, has that increased the workload for the women? And I think that is an issue. But also the stay-at-home has issues. How about where children are being stuck with, we've talked about gender-based violence with abusive partners. How about sexual violence where children are being stuck with people who are potentially abusive? And in a context where court can only be moved to sit in an emergency, how long can that evidence be preserved? So in that aspect, you're talking about increased care work, but also you're talking about access to justice, and all these are human rights affairs. Then with the closure, we talked about limited access to food, but also there's a threat of unemployment. We've seen many hotels downsizing their staff, and the negotiations are now on with government to ensure people are not laid off. But what does this actually mean? When hotels are saying they are not going to keep workers when they are not working. So how do those workers survive? And most of the workers in tourism and those service industries are also females. What does that mean for them when they go back home? We've seen women struggling so much and staying in markets and being praised by the president. Are there services for them? When I have to stay in a market with my child, whether I have a mosquito net, are our markets built to that capacity? We've talked about also, they talked about delivering, Professor Ben said there should be a way of delivering some essential services to people at home. And indeed in Kampala, they are doing that for HIV treatment. But how about upcountry, where you cannot get a man on the bicycle hired by a particular health facility to ride around? We've seen also issues with transport, especially with disabled people. One thing crises like this do is they exacerbate already existing inequalities. So while someone can walk, a disabled person may not even be able to access an RDC's office so as to get a travel permit. We've seen some on wheelbarrows, some who we are not seeing, we don't know what is happening to them in the households. So there are transport challenges for health workers. Professor Weiss spoke about those. And here we can just look, shine a touch on stickers. Stickers were provided to medical workers with cars. How many of our frontline cadre nurses and enrolled nurses have cars? Are they the ones that actually have to walk, or is there a bus system that will take them? And I know there have been 2 cases where nurses have been beaten off a border. So that also is something to watch. And I know my time is running very fast, but I also wanted to speak about what does stay at home mean for people in slums, whereby your veranda is also your workplace and the military cannot tell the difference between someone who is cooking on a veranda or whether this person is actually trading and is not at home. So there are challenges there. And of course, with time, the president guided that people's compounds should not be attacked. And this was good guidance. But basically, what are we trying to say going forward? Of course, there are issues of special groups like the disabled. They have talked about those. There are the issues of refugees, because we've seen refugees in Kampala are not being provided with food because the food was for nationals. But remember, their spouses can no longer work, or they themselves cannot do petty trade. So when you jump one home because a refugee and the mother and the child are left wailing, like we saw in Somali, I think 2 or 3 weeks ago, and the police officer was telling them, if you're refugees, you should be in the refugee camp, not here. What does that do to that mother whose responsibility is to provide for the home? And in refugee camps, I know they have small gardens, but the movement restrictions have not allowed them to go to their gardens, even when the president said people in rural areas should access. But you know, when you're a refugee, there are also more other restrictions that come with you. So what are we recommending in all this? As I started with saying that crisis of already existing crises. So one thing, as Professor Isa said, we need to strengthen our healthcare system with referral. However, for me, I wouldn't just start with the lower level health facilities. He himself said health begins in the household and we only go to the hospital to fix what has broken down. So we need functional livelihoods in homesteads. We need improved health practices in homesteads, but people are not going to wash hands when they don't have access to water. People are not going to practice good sanitation when they don't have access to proper sanitation and toilet facilities. So going forward, we need to improve livelihoods and household livelihoods. If people can do vegetable gardening in their backyards, so be it, and they will not have to die of hunger and the nutrition that Dr. Bessie was talking about. And remember, we've not even talked about vaccination for children who are not going to be vaccinated if they are delivered at home. So fixing a healthcare system begins from a home. A home is a gendered space. What are we doing about that home? We have to ensure that there are mechanisms of dealing with things like gender-based violence in homes. Let's make homes safe for everyone who is there, so that both females and males can excel. We need proper interventions. We've seen mobile money is not charging money now. We've seen, I think they are advocating for phasing the loan repayments. We need these kinds of interventions so that the poor can also survive in business and they can look after themselves. Of course, food relief being provided, but should pay attention more to vulnerable households, people who are disabled, and people of that nature. And going forward, what is the lesson in all of this? That gender matters in both disease and its control. And that the households where diseases emanate from or control of diseases emanate from are gendered spaces where gender inequality has persisted historically. But we need to be able to combat this. And also we need to speak to socio-economic development world over. This is the opportunity for us to reflect on society and make our countries work. Because we've seen we can no longer jump onto a plane and be treated elsewhere. And so we need to make our homes work. We need to make our households work because a gender equal society works for everybody. Thank you very much.
Thank you very much, Professor Salih, for having discussed such a broad topic around gender implications and then also challenging us in terms of the gendered nature of the responses of the pandemic, but even also of how we are going to move ahead. We're going to sail now into mental health. Because as Professor Sarah was speaking, was talking about some of the challenges we are facing in the home, some of the challenges we are facing to adapt to the new changes, but even also that the services that have to exist and to continue amidst managing the pandemic. I'd like to invite Professor Segane Musisi to come and have a conversation with us regarding COVID-19 and the impact on mental health. Professor Musisi, you're welcome. Professor Musisi, are you there? Professor Musisi, are you there? If Professor Musisi is not there, can we have Rose to continue with the conversation around frontline healthcare providers?
What has happened?
I hope you can hear me well.
Hello?
Hello. Let's have Professor Musisi first and then get back to Jane. To Rose.
Do you hear me now?
Yes, very clearly.
Very good, very good. I was saying good morning to everyone and thank the previous speakers. My issues will mainly concern on mental health and what can be done to try to right what I think have been missing gaps. We have to realize that COVID-19 is a pandemic and it's a public health emergency of international concern. We also have to realize that the mode of infection is respiratory and we all breathe every day and it comes in invisible droplets. And sometimes it has asymptomatic carriers, so we don't know who may be having it and giving it to us. It has high fatality, although most of it is mild, but about 15% it is severe and 5% is quite critical. The death rate between 2 to 5%. It means that the response to it must be a public health measure of drastic proportions and of immediacy. Being highly infectious and fatal makes it very psychologically traumatic. And the behaviors of people in a pandemic will be very much dictated by their psychological feelings. So it causes extreme anxiety with feelings of helplessness, hopelessness, panic, stress, and a tendency to what we call catastrophizing, thinking that everything is a catastrophe and having doomsday feelings. If prolonged, such feelings can lead to post-traumatic stress disorder, depression, and can send people into abusing substances like alcohol and drugs. And the population will be stressed as well as the frontline workers. We have talked a lot about the health workers. I'm going to substitute that for frontline workers because there are many people involved in a pandemic who are not necessarily health workers. For example, law enforcement officers. But as we realize, the president correctly said that the measures taken are not just for inconveniencing people, but a matter of life or death on a large scale. But these measures are drastic and cause mental health concerns. And of course, Uganda had set up a national task force to address the response. We will not go through all the measures, but most importantly, the most important measures have been the ones of social physical distancing, those which have caused mental health concern. Testing, isolating, and quarantining travelers and contacts, treating all people even if they are symptomatic. And there's no choice in whether or not you accept the treatment. You have to have the treatment because it is a national emergency. So the Ugandan response has been to prevent community spread following WHO guidelines. But like we said, the pandemic is traumatic. The containment measures themselves are also drastic and stressful, and involve frontline workers who get overwhelmed, fearful, and frequently burn out. This also includes non-health personnel like policemen. As we have seen in the news media, some have actually been infected and are fearful themselves of also going to the front line. So there have been gaps in the response, and these have contributed to the mental health fallout because of the non-realization that the pandemic and the measures taken themselves cause mental distress. As we know, at present in Uganda, there is no national psychosocial response to mitigate the national mental health fallout to the population or to these frontline workers. So these gaps are very many, but just to briefly talk about them, for example, we needed to mitigate the economic downturn, which I think many workers have talked about, including Dr. Sally. The food handling, looking after children, having no space for physical distancing in high density housing, the family tensions and domestic violence that has ensued with the stay-home orders and the curfews, the ensuing substance abuse, the depression, which has gone on to making people become suicidal and even homicidal, including what we hear on the news. Even last night, you heard about the guy maybe in Mwende who killed his children. We have this social cultural void, which again, people have talked about, not being able to greet or visit neighbors or even talk to them or relatives. And we then have the vulnerable groups, migrants, refugees, the homeless, street children, people with physical disabilities, people who live on islands, the elderly, and many more. And we have had that limited access to health care, people with existing conditions that must be looked after on a regular basis. And not just, people usually talk about hypertension and diabetes, but there's so many medical conditions. There's cancer, there's pregnancies, and also daily emergencies, and also other diseases like malaria, typhoid, all these things that need attention. We also have the mental health conditions themselves, which tend to be, sometimes sudden, like in epileptic convulsions, or chronic, like in psychosis and stuff like that. Then we have the protection of frontline workers with personal protective equipment, not just masks, but gowns, gloves, and so many others, including protecting people like policemen or food distributors, who, if not protected, become infected and suddenly become very distressed as they go to work every day. And then we have got another problem of unsupervised law enforcement officers who have used excessive unnecessary force when dealing with people, not knowing that people are already distressed. So the key question is, what should we do to avoid this mental health fallout? And the most important thing is that at the very beginning, as we were planning the Ugandan response, we should have also planned a psychosocial response in a disaster. We have had many disasters in the past, and we also continue to have disasters. Even as we are having this present disaster, we are also having other disasters like floods, for example, or rainstorms, which you have been seeing on the news have been distressing people. And all of these cause mental health problems to people. So most importantly, I'm going to divide the response that is needed in 3 categories. What needs to be done immediately, what should be done in the short term, because it is likely that COVID-19 will stay with us for a longer time, and then what should be done in the long term. First of all, the immediate response. In setting up the psychosocial response, we need to set up crisis counseling and support, which should address people who have been identified as being COVID positive. It's very stressful to them and their families and their contacts who get traced and tracked and are usually quarantined. People in quarantine, and of course their traced contacts. People who face stigma, like those who have just returned from abroad, or people of Asian ethnicity, all those who are COVID positive but now have been cured of the disease and are being discharged. Then we have got to face the possibility of death and therefore grieving and anger, which may follow this. Fortunately, in Uganda, we have not had any deaths related to COVID-19, but sometimes we think it's just a question of time. And then there's the whole population who we call the worried well, but who become panic-stricken. And because they become panic-stricken, they make decisions that they regret later. The second point in the immediate response is debriefing. We need, by this we mean talking to and preparing frontline workers, including health workers, as they go in and also as they come out, involvement with COVID-19. Because these people are directly concerned with managing COVID-19 patients. The idea itself is scary. We need to debrief law enforcement officers who are deployed, knowing that they're dealing with an emergency situation, which is frightening, and they need to be humane instead of using blind force. We need to debrief anybody or any officer involved into this response, including food distributors and government officers, and the way they approach the situation. We also need to debrief helping agencies like the Red Cross, UNICEF, and others. Now, we need to set up emergency mental health interventions in all government and non-government hospitals, including all of these missionary hospitals. We need crisis helplines where people can call for help. These have not been set up. All health centers and health clinics should be able to handle people with acute mental health breakdowns, and they should be prepared for that. This should be part of the psychosocial response. We need to involve the following in this psychosocial response: the Uganda Medical Association, allied professionals, an association of nurses, paramedicals, psychologists, pharmacists, lab technicians, social workers. And we need to also involve helping mental health NGOs like Basic Needs or Uganda Counseling Association. So, in other words, we should be able, or we should be now looking into setting up a national COVID-19 psychosocial response initiative with briefings to the president through the National Task Force. In the short term, as we are going on with this epidemic, or pandemic rather, we need to begin to think very serious about training of trainers for psychosocial response for regional referral hospitals, because these hospitals have also been prepared to handle COVID-19 patients. It will make it easier for them to accept victims and to treat them in their locations. We need to supervise them, these psychosocial responders, and usually the supervisors tend to come from centers where there are mental health facilities, like Mulago Hospital or like Botanical Hospital. We need to protect vulnerable populations, the homeless, orphans, street children, refugees, people who live on islands, people with physical disabilities, the mentally ill who may be roaming streets, people in extreme poverty, and people in overcrowded housing, call them slums. We need to prepare and equip mental health clinics in government and non-government hospitals and health centers. It is very unfortunate that mental health units in many parts, many regional hospitals have been converted to isolation centers. Yet these mental health units were handling mental health patients. The question is, what is going to happen now to these mental health problems? Where have they gone? Knowing that many of them have chronic illnesses that must be cared for. We should prepare and we should procure AP tents, which should be used for isolation instead of using mental health units. We have used AP tents before in Ebola and cholera breakouts. They worked very well, and they should work very well now, but not converting mental health units into isolation centers, because that leaves a gap of mental health care. And there's no health without mental health, as we also know. Also, these AP tents can be used in the future. Then we should talk about a long-term response. We should have plans for follow-up of these frontline workers for their mental well-being. Many of them will get long-term complications from what we call vicarious traumatization. They'll get post-traumatic stress disorder. They'll get depression. They may become addicted as they have to face the pandemic and seeing victims every day, especially if it becomes big and we have deaths almost every day, as we have been seeing in some of these countries abroad. The frontline workers include health workers. They include law enforcement officers. We have seen some of them getting infected, like what happened, I think, in Masindi recently, and also in Jinja. Media workers, these people are always involved in disasters and mass traumas, and we see them getting very distressed. We saw them, for example, being very distressed when there were the Lugogo bombings in the past. In the Ministry of Health, we need to set up a permanent coordinator position for psychosocial response strategy to handle these mass public health emergencies. This harmonizes, or should be harmonized, with the national strategy of disaster preparedness, including logistics and the budget for them. Because these emergencies are complex health emergencies, and they will always happen, and we should always be prepared for them. We should build capacity and health staff in regional referral hospitals in mental health and psychosocial support, and empower them to carry out rapid psychosocial needs assessments and then lead interventions, like we saw in Sana, which was Northern Uganda psychosocial assessment during the Kony Wars. We should integrate psychosocial support into the training curricula of all health workers, including psychologists, social workers, counselors, and law enforcement officers. We need to set up family services divisions or secretariats at all administrative levels, LC1 through to LC5. This caters for domestic issues, including extreme poverty, orphans, domestic problems, which themselves increase in disasters. So in conclusion, the COVID-19 pandemic is a global tragedy, and it creates a global complex health emergency with catastrophic psychosocial consequences. WHO defines health as a state of complete physical, mental, and social well-being, and not just absence of disease or infirmity. COVID-19 is a complex humanitarian emergency, and as in all complex humanitarian emergencies, providing and ensuring mental health interventions safeguards human rights of all and ensures social justice as we address the pandemic. It is very important, as you saw Professor Benton stating, that whatever we do, we must observe human rights, including the right to access healthcare. But as you know, now in Uganda, there's a glaring absence of a national psychosocial intervention initiative in this pandemic, making it imperative that we set it up to safeguard the mental well-being of everyone and all responders to this pandemic, and to all Ugandans at large. Thank you.
Thank you very much, Professor Segane, for opening our eyes to mental health, impact of COVID-19 to mental health, and some of the things we didn't know that is what it is, but probably having answers to issues we struggle with on a daily, like anxiety, but even also how do we situate reality and doing things differently. I'll now like to implore upon you to please continue sending in the comments, sending in your questions under the Q&A, as well as in the chat. And also, I know those that are live on Facebook, you're sending in your comments. I know some of you are asking where you can get the briefing papers, the technical papers, the 4 papers. You can access them on the JAS website, as well as that is out there on the screen. You can even call our toll-free line 0800 313 131, 0800 313 131, and drop your question. You can also share your questions via WhatsApp. If there's any of the team members that you know, they share via WhatsApp. Let us keep the conversation going, as well as on our Twitter handle, so that we are sure that we get all your questions and can respond to them. I'll now invite Rose to come in and share with us around frontline healthcare providers. You heard Professor Segane talk about frontline providers. And if still technology is conspiring against this, I'll take the opportunity to summarize her paper, and then we get into the Q&A. Rose, are you there? Rose, are you there?
Yes, Salome, yes, I'm here. You can hear me. I'm here. Can you hear me?
You can hear you keep breaking, but you can hear.
Yes, Salome, can you hear me?
Yes, it's better now.
Okay, thank you so much. Thank you so much. I'll try to be as fast as possible. We developed a paper within CEHAD that deals with safeguarding the interests of the frontline workers against the fight against COVID-19. Here we specifically looked at health workers, one of the frontline workers who are most at risk when it comes to the fight against the pandemic. And within this paper, we looked at the challenges that they are likely to face and how the law goes ahead to protect them and their particular rights in everything that they do. First of all, we all know that health workers are the front line of the fight against COVID-19.
Rose, are you there?
Neglected in terms of prioritization, getting to them of getting personal protective equipment on the top of the list for equipment that can be procured to help them to protect themselves. Statistic-wise, we know that when Ebola attacked West Africa in 2014, over 340 health workers lost their lives because they were dealing at the front line and working with people who had Ebola at this time. By the end of March, we had over 3,900 health workers who were infected with COVID-19, and this was just in Spain alone. Now, we do not know what has happened within April and what is going to happen within May, but we know that these numbers are going to be pushed further and further up. The Ministry of Health, in one of its briefings, stated that the expected infections of COVID-19 are expected to peak at 18,000, and that is within Uganda. And over 1,000 people are going to need critical care. The people who are going to take care of these people are health workers. But just not only puts them at risk, but equally put their families at risk because they are not working from work, but they are working from home. We also have these health workers who are not dealing directly with COVID-19 patients, but they are dealing with patients who are on a walking basis. They do not know whether these patients have COVID-19, but they still do not have personal protective equipment. The challenges that they already face include the fact that there is an inadequate healthcare workforce. Already, this is something that we have highlighted time and time again to the government, that already we have very few health workers. They are too few, and now when the pandemic comes to hit, we see the Ministry of Health rushing to try and cover up some of these gaps by recruiting new health workers. We also know that our health workers are not well facilitated in terms of health goods, but also in terms of equipment. They do not have the necessary things that they need to work for gloves, face masks, etc. Name it, they do not have it. We also have a problem of information gaps. Whereas some health workers have been oriented and trained on how to manage and combat COVID-19, a majority still do not know and are working with what they have off the internet or what they speculate as having dealt with in other pandemics. Then we also have a limitation and an inability to get to work because of the embargoes that have been placed on private and personal transportation. Their needs include the fact that they need appropriate personal protection equipment. It's not enough that you give them masks, they also need shields. They need everything which is appropriate to enable them to combat this virus. They also need the latest information, but above all, they also need, we all know that they are going to face emotional and physical exhaustion. WHO released some guidance in terms of the rights of health workers during this time. And one of the guidances that they gave is that the employers, here we are looking at the government, should take all responsibility for all means to minimize occupational safety and the health risks that may be by health workers. The responsibility of the government, health workers, of infection or risks that may pertain to them. They also need to be provided with information, instruction, and training on safety. You shouldn't just procure equipment and throw it within the hospitals. They must be trained on how to properly use and dispose of equipment. Then the PPE provided, it must be in goods and in enough stock. Here we look at the fact that health workers shouldn't be given masks or gowns and they have to reuse them, yet the recommendation is that they should be disposed of as soon as they are. They must be in enough quantities. Then they have to also maintain appropriate working hours. Here it's not enough for health workers to work day and night, but we also have to try and make sure that the health workers get enough rest so that they get a rest from having to deal with patients at all time. Then the government must work in consult associations in order to see how Salome, can you hear me? Salome?
You keep breaking.
Okay, can you hear me now?
Yes, we can hear you. And try to summarize.
Yes.
You want to have a discussion.
So I was saying that the WHO, okay, yeah, I'm just going to jump. Yeah, so the WHO health workers, they feel they are at risk. So where health workers do not feel comfortable, or they feel that they are in a dangerous situation, or that they haven't been given enough and adequate protection, then they have every right to remove themselves from that situation by laying down their tools. This particular guidance is not taken out of the blue, but it's actually laid down within our laws. And if you look at the brief, you'll notice that we have had comprehensive and extensive discussions on the Occupational Safety and Health Act. We also have an extensive discussion on the standing orders of the Public Service, on the Employment Act, on the Workers' Compensation Act, and on the Labor Unions Act, and on the redress that can be sought by health workers. The different recommendations that are being made in that particular brief is that, number one, we have to respect the rule of law and human rights when it comes to health workers. They shouldn't be beaten, they shouldn't be denied stickers. I have some friends who are not even health workers, but they seem to have stickers. And you keep asking them, why do you have stickers when all you're doing is staying at home? But when you talk to health workers, they actually do not have stickers. We have to include health worker force, because then they will be able to assess and tell the correct needs of health workers and deliver them to the task force. We also have to create safe and satisfactory working environment for health workers by prioritizing the procurement of personal protective equipment and sensitization of health workers on appropriate safety measures. And we have to avail transportation to the health workers with or without stickers. And we also have to talk to the communities, because we know that they are not working from work, they are working from home, they are commuting. So their community within itself is very suspicious of them, and therefore they are likely and susceptible to face stigma. So communities have to be oriented so that they can be able to accept the health workers as they are. And that was my presentation. Thank you so much.
Thank you very much, Rose, for having taken us into the realm of the frontier healthcare providers. What are their realities as they are trying to give hope? Many of us are struggling with allowing the new reality of the pandemic to sink in, but also the challenges that they are facing, how these are being overcome, as well as the recommendations. Now, we've heard from one keynote speaker who really grounded us on the right to health, issues around ethics and data, issues around not politicizing this, the response, but also the role of civil society. What are some of the things that we need to do? We can't fold our hands and say we are under lockdown. We need to get on our feet. We need to get on the bicycles. We need to go out there. We need to complement, because COVID-19 is our problem as well as a wider constituency of citizens of the world. And then also in the keynote speech, there was an issues around health rights as human rights, and the reality that the fact that we're still pushing to ensure that health rights are respected. That is the reality that COVID-19 found, and what it implies in terms of the response and its effectiveness. And then talked about something that I'm trending of late around the state of emergency. And actually, in the land professor's view, it is not necessary. It should be the last option, because it might lead to a lot of disorder, but also a lot of rights violation. We're not yet there as a country. And then, of course, continuing to organize, situate ourselves in the new normals around virtual organizing, around using available means to organize, but at the same time, carrying everybody along. We move on to a summary of what Professor Waiswa, talking basically around COVID-19 and our healthcare system, that managing a pandemic of this nature thrives on the kind of healthcare system you have, the healthcare system which is both the clinical but also the community systems, and how that has worked, and also where the gaps are in terms of being effective. And then also he is concerned about the rising rates of maternal mortality, but even also where permissible travel without the RDC letter is only for pregnant mothers. But what about antenatal care? What about other pending maternal and child health complications that people are facing? And then also the fear that as we have pushed people out of having babies at traditional birth attendants, we may have to see that going up again, because they're the ones that are nearest, but also with the lockdowns and the limitations on travel, it becomes a bit difficult for people to walk long distances. And then, of course, having a realistic balance between what we call essential and non-essential healthcare services becomes very important in managing a crisis of this magnitude. And then Professor Sarah really talks about how life is gendered, how a crisis of this nature really deepens the existing inequalities that are gendered across race, sex, sexuality, gender identity and orientation, social class, ableism, who is able, who is disabled, rural urban diversities, and even also the over-medicalization, including the terminologies that are used. And what does that mean in terms of inclusion and exclusion? Who is included in this information and who is excluded? And then also how we need to be on the lookout for some of the gendered nature of the response in terms of staying in a domicile with somebody, for instance, who is violent. What does that mean to girls and women increasing their labor, but even also the expectation? How will we take women back to the public sphere when they spend a whole year at home because we have to stay at home, or maybe they've lost an income because of the loss of jobs? And then we go on to Professor Segane Musisi, who is talking about what does it mean, a space for physical distancing. For instance, Africans are generally social beings. What does it mean when they tell you don't even greet your neighbor? What does it mean we are constantly anxious in terms of fearing to get sick, in terms of not sure that if you get sick, you're going to be treated, in terms of seeing the figures rising every day, in terms of unemployment and loss of income? What does that do to you? But also more worrying that the fact that we have a national response to COVID-19, but it didn't have an attached psychosocial response mechanism, and the importance of having that. Lastly, Rose brings, lastly, of course, we have a number of comments, which comments are really around what do we need to do? Where are the gaps? So the time is now. I know some of us have been dying, and I know some people have had their hands up since we began. And this is how we are going to manage ourselves. Remember, all our microphones are muted. Even mine, whenever I stop speaking, is muted. If you need to make a comment, raise your hand. Virtually, there's where you're supposed to raise your hand. And then I'll pick the names of those that have raised their hands. And once your name is picked and I read your name out, please, your microphone is going to be unmuted. Proceed to ask, or we are going to send you a message that your mic, you should accept that it is unmuted, and then you ask your question or comment. Please be as brief as possible. I know those of us on Facebook, some of you have sent your comments. Please keep them coming. Those that are sending your comments on the JAS website, www.jasprogram.ug, send them through. And even those that are sending on our Twitter, please continue sending them through. Our panel is a very competent and able panel, and we would like really to hear your voices. Thank you very much. And now we are open for the comments and questions, as well as those that we have that already 45 in the Q&A section. So can we see the hands? Here in my, here I have 4 hands. I'll begin with Alice Colette Alum, and please tell us who you are and which part of the world you are, because this is an international webinar, and then you ask your question. We'll begin with Alice, then Koma, Dastan, and Galaxy, Jeff Okoa. Alice? Alice, your microphone is still muted. Can we move to Koma?
Hello?
Yes, we can hear you.
This is Koma Kech Job. I work with SEHAD. My question is to Professor Ben. He talked about participation during this period. I would like him to shed more light on the participation of local governments in the COVID-19 fight. There, for example, the National Parliament is currently working, and yet district local councillors are not conducting council meetings to actually appropriate for funds and the like. So I'd like him to shed more lights on the participation of district local governments, especially where the constitution has actually decentralized provision of services. Thank you.
Dunstan Mubangizi. Let's move on to Joan, if Dunstan is not getting on. Joan Kayambi.
Hello?
Hello? Hello, this is...
Hello?
Can we have Joan speak before Dunstan?
Joan Kabayambi, I work with Zonta International. It's an organization that empowers women through advocacy and service. And okay, I also used to be a CDC fellow with CHAD 2013-2014. I would like to add my comment that issues of nutrition for mothers in such a time need to be discussed intensively with all the great intensity they deserve, and giving priority to lactating mothers and pregnant mothers, mothers with conditions post birth, fistula and other conditions. They need to be discussed because they are out there with no voice and nobody is talking about them. Then community awareness should be multi-sectoral with all aspects and all sectors inclusive, on maternal health, on mental health, on gender, like Professor Sally is saying, and the whole of COVID response that Uganda is doing should not only center on medical, but all these issues should be looked at. So like Sehad, what are we doing to bring out this, especially on raising awareness? Thank you.
Okay. Thank you very much. We are going to move on to Dunstan.
Yes, I'm online. Sorry, are you getting me?
Yes, I can hear you loud and clear.
Yes, sorry, how are you? And nice to catch up with you.
Welcome to the webinar.
Yeah, I'm called Dunstan. I am based in Dhaka, in Bangladesh. I work for United Nations Population Fund. My question, I have one question for Professor Sari. She talked about the issue of sexual violence in a situation that now courts cannot sit in emergency, and of course which undermines the principle of access to justice. But considering, I just want opinion, considering that there are certain ingredients to prove rape and defilement and have a little bit tagged to time, you know, how do you think, what would be her suggestion in terms of engaging government to ensure that the evidence doesn't die and these the victims of survivors of sexual violence may not be denied justice? Thank you so much.
Thank you very much, Dunstan. Let's now have, I need to gender balance. Let's have, I saw a hand up here, Elsa Zawede. Elsa. Elsa?
Okay, thank you. Can you hear me? Hi, can you hear me?
Yes, we can.
Okay, my name is Elsa.
Okay. Elsa, are you there?
Yes, can you hear me?
Yes.
Okay, so my name is Elsa. I'm in Illinois, America. I have questions for Professor Waiswa and for Rose. For Professor Waiswa, I was wondering if the pandemic has not increased the rate of abortion, just because mothers could be afraid of, spreading the disease to the unborn children, or even accessing hospitals because they're scared of catching the disease and maybe opt for abortion. And then my other question is, has any information been drafted to ensure that that mothers get the assurance that breast milk does not lead to spread of the disease to their breastfeeding does not lead to spread of the disease to their children, and such that they don't give up on breastfeeding, which I think is a very essential aspect for pregnancy and breastfeeding mothers. And then for Rose, I was wondering whether SEHUD could push for presumption of illness for frontline workers, such that they can easily file for workplace compensation. And then also, and there are some situations where telework can be allowed, so that the health workers can sometimes work from home online and not go to hospitals, because I believe that is also another way of protecting them. Thank you.
Thank you very much. Let's have Remy Africa. Remy Africa.
Hello?
Hello, we can hear you.
Hello, do you hear me?
Yes, we can hear you. Proceed with your comment or question.
Thank you so much, Sehad, and for organizing this, and all the amazing panelists. As I've mentioned, I'm Rosemary Nakame from Rem East Africa. And at Rem East Africa, part of our COVID-19 response involves collecting stories from rural healthcare workers about their experiences dealing and serving COVID-19 patients and the challenges they're experiencing. But let me just give us a very snapshot of some of the challenges, and I engage some of the panelists. Some of the challenges we're hearing from the rural healthcare workers are, for example, the stigmatization when they go back in their communities after handling these COVID-19 patients. And some of them are continuous, also reoccurring the lack of PPE and the rest. Now, while we're talking about urging the government to provide PPE, I'm asking, isn't there a role we could play as civil society to engage government to be present in the task force meetings, or to be engaged regularly in the task force meetings and provide continuous support in availing a holistic response? And number two, I also heard about Professor Segani's urge of a psychosocial response. And I do agree with that, but I've heard from Uganda Red Cross, head of COVID-19 response, that UNICEF is actually providing psychosocial support to patients and those in quarantine and their contacts. Now, it might seem that there is a lack of enough information going out to the public, or maybe we could engage them so that we support the response and also increase the amount of information available and address the gaps that are present. So that's my submission. Thanks so much.
Thanks a lot. We'll have Robert Opiti, Matthias Mulumba, and Solomon Atim in that order.
I would like to thank Sahad for organizing this meeting, and I would like also to thank in a special way the discussants that were able to speak quite in a detailed manner. Mine will be straight to Professor Professor Ben, and speaking of protecting the right to health, I see that we need also to guide government on how to handle social distancing in school when school opens. What is his take on how to practice social distancing in class, dormitories, dining, and etc.? Thank you.
Thank you. Salome Atim, then Matthias. Salome, are you there? Are you there, Salome? Or you're having problems connecting? Can we have Matthias Mulumba?
Myself. Okay, thank you. I just wanted to see my mic. I was not seeing it from my screen. Is it hearing me?
Yes. Can you please introduce yourself?
Okay, this is Matthias Mulumba from Uganda, Kampala, from CEPAD is Center for Participatory Research and Development. I'm happy to have been involved in some of the COVID activities. Right now, we are at the Vector Control Division, Ministry of Health, where we are trying to do larviciding and mosquito control in markets, according to the presidential directive. What I've found about the civil society involvement in many of these activities is that I think some people have information, but they're not giving it out. There are gaps, real gaps within the government interventions where civil society can really contribute. But you have to find a way of how to get there, and then probably you can't do much because you're one person. I think we need to be more organized the way we have been organized. I saw Richard Sewachirianga in Uganda sending out some messages about psychosocial support, for example. It was an email which I also saw a bit late, and I had to say we have maybe one person from my organization who is a psychologist and can support this. But how do we get more coordinated as civil society as we have always been in order for us to support many of these initiatives, especially in emergency? Emergency, you don't have time to plan, you don't have time to sit, but there should be a coordination mechanism that can help us really stir up the civil society to act. That's my comment. Thank you.
Thank you very much. Let's have Galaxy 4 Jekoa and then Fatuma Nakazi.
Hello.
Hi, we can hear you. Hello, can you please introduce yourself and your comment or question? Galaxy, you're on. Okay, let's now move to Salome Atim.
Can you hear me?
Yes, we can hear you.
I'm saying, I'm wondering how is Uganda really prepared to handle epidemics? This Ministry of, I don't know, disaster preparedness and the like. I'm looking at the food distribution and others, preparedness on.
Introduce yourself first.
Hello?
We have an international audience. Please first introduce yourself first and then you give your comment.
Okay, sorry. My name is Salome Atim. I sit on the Global Fund CCM board and I'm a community person generally. So I'm appreciating the panelists and Sehad for giving us this opportunity to share. and plan for the country as civil society as well, or make our voice be heard. And my first comment is I am a bit disturbed. I feel like as a country, we are not really prepared to handle epidemics. I know we have this Ministry of Disaster Preparedness, but I don't know how well prepared it is really to handle disasters. Because when I'm seeing, as presentations are being made on TV, I don't seem to see much of their participation in this. And my question is going to any of the panelists: how prepared is this country really to manage epidemics? And then the other one is to the good professor who talked about mental health. While I appreciate mental health so much, I also note that I think many of us have not yet appreciated the importance of mental health, or do not see how it interfaces in our daily lives. And maybe that's why we do not prioritize it. What plans do we have to make sure that as civil society, as individuals, as a country, we do appreciate issues of mental health, so that there's adequate funding, and so that it's also given the space that it deserves? You can see when some of the workers or employers, when you say I'm having I've broken down, or I need to go for a leave of 1 day to take off sometime, they don't seem to understand what is your issue. Just remain here and work. We don't yet appreciate the issues of mental health and how that affects your general life and livelihoods. Thank you.
Okay, thank you very much. We'll have one last one from our two managers selected earlier, and then I read for you 2 or 3 from Facebook, and then we'll have the panelists respond. Fatuma? Fatuma? If you can't get Fatuma, can we have Samuyaba John Bosco? Samuyaba?
Can you hear me?
Yes, loud and clear.
Thank you very much. I would love to thank you, and I thank the wonderful panelists for the wisdom they have given us. My question number 1 goes to Professor Sarah. She gave a wonderful presentation about gender dynamics. I was asking how specifically the current pandemic has contributed to an increased rate of gender inequality in Uganda. My other question goes to Professor Waiswa. He gave some very interesting statistics. So I was wondering whether we are keeping track of the current statistics of the same, given the pandemic, because there could be a very alarming statistics when we try to find out what is happening currently, given the previous few weeks of the pandemic. And then the question, another Segane Musisi, he talked about the National Psychosocial Response Team, which was quite interesting. So I was kindly requesting him to shed some light on how we can make this a reality, because I personally think it has been long overdue. And then the last question goes to Professor Ben. Professor Ben commented about the state of national emergency. I was wondering, I was asking, how is the current scenario better than the state of national emergency? Because later on, I saw some parliamentarians blaming the president for not declaring a state of national emergency. So I was wondering how this scenario is better than a state of a national emergency, and whether the parliamentarians were blaming the president out of not being very well informed. And then the last question is, I wanted to know how elitism and over-medicalization, how those two have been a problem, because 2 panelists commented about them. I really want to know how those two are a problem. Thank you very much.
Thank you too. Now I'm going to read the Facebook questions and those that were sent via our Twitter handle. The first question is from Flavia Zalwango Mugoya, who says, police officers also need to observe all the social distancing measures. They continue to abuse these guidelines while they interact with people and while they are doing arrests. And yet they have no protective gear. And then we have another question that comes in from Facebook that talks about COVID-19 has affected people. How are we going to make sure that those traumatized at the community level are supported? And then we have another question from Rachel Magola to Professor Ben. How do the right to health be ensured in the COVID era when there is lack of the same in the norm of Uganda? Much has been done, but there are no budgets. They lean towards sectors like information and security. And when would Parliament think of revamping healthcare systems and infrastructure? And then we had another comment from Mile P. Kevin on Facebook. I'm interested in how gender dynamics will cope in accessing sustainable food and balanced diets during and after the pandemic. And then another one is from Frank Loyepo. Professor Waiswa, how will the CSOs be coordinated when they are not in Kampala? And then, of course, lastly, there is an anonymous a question that says there are allegations of sexual favors from the Food Distribution COVID Task Force Office. You must give sex if you're to get food. Those are there, and that is something that has to be addressed as we are looking at SRHR and the COVID-19 response mechanisms. So over to you, my panelists. You're free to shoot from any angle, respond to the questions and comments, but let us all remember time is our greatest enemy. We can't answer all the questions. The conversations are going to continue on the Twitter handle, the JAS Twitter handle, CEHAD Twitter handle, the Twitter handles of all the 7 partners in JAS, but even also on the hashtags for this particular conversation. So let's have the panelists respond, and then we try to wind down this webinar. Thank you.
Yes, Salome, can I go first?
Sure, go first.
Okay, I think I had only 3 questions, so I'll start with the first. To Elsa, on the presumption that illness is due to the nature of employment, yes, this is embedded within our Workers' Compensation Act, and it's a route that can be tackled by health workers if they want to claim compensation if infected by COVID-19. The only challenge is the requirement to prove disability, which may push up your damages, and the fact that this particular act was not made in light of a pandemic being attacking a country. So there are a bit of challenges on that, but it's an opportunity that can be exploited. On the issue of telemedicine, telemedicine has not yet been explored by our law, as far as I know, but we are definitely pushing with the Ministry of Health to, yes. Can you hear me? Yes, I was saying that, yeah, for telemedicine, we are pushing with the Ministry of Health to deliver guidelines to help health workers to be able to use that avenue. And then someone had asked about the human resource gap for health workers. The gap right now stands at 25,000 health workers. That is the gap that is required in order to fill all the slots that are needed to appropriately cover the healthcare system. We have only 2.28 doctors for every 1,000 people, not just doctors, but nurses and midwives. And right now, our average staffing lies at 70%. So we have a 30% gap that needs to be covered. So when we talk about inappropriate or inadequate health staffing for the public healthcare sector, it's actually a very big problem that needs to be urgently addressed. Thank you so much.
Sorome, can I come in? Hello?
Yes, Prof, we can hear you.
Hello, I think you just proceed.
Okay, thank you very much. I'll try to be fast. I think the first question was for Komakecho Sehad. On question of participation, I think it's a comment. I agree with you, because with the decentralization, which is really devolution of powers, we thought that these local governments should be active. So in accordance with the Constitution and Local Government Act, I agree with you, they should actively participate in this response. Number two, I think Sarah Sari talked about this on over-medicalization of COVID. Maybe should answer that. But let me emphasize that in the opening part of my presentation, I emphasized that the right first moves beyond medical care or health care and goes the social determinants of health. When you internalize general comment number 14 on the right first that has tried to interpret the steps that must be taken by states in detail, one of the requirements, for example, is that government should put into consideration gender responsiveness in all activities they handle. And Sally has explained that gender moves beyond the social cultural construction to even go to class, religion, sexual identity, orientation, etc. So I agree that the thing has been over-medicalized. We must go, as Professor Wasso has pointed out, primary health care, what in political economy of health we call socializing health, and even question this neoliberalism, which study has extensively written on. Number three, social distancing. This is a very difficult one. I believe other panelists will come in. Social distancing in schools. Maybe I'm one of the people who believe that it's not time to open schools, colleges, and universities. And I would like to reiterate the president's message, which I'm happy has been shared on a lot of space on social media. What we are handling now in this war is health and life. Those are the primary considerations. Controlling children in school with our limited spaces in universities where we teach students 200, 300 in a squeezed class is difficult. But should the government go ahead to open the schools, it should ensure that there is proper spacing, and this one could be done by devising, like in universities, even schools, creating tents, for example, erecting tents outside the normal classroom. In other words, you divide the classes, maybe in streams, to ensure that there is enough spacing in the class, and ensure that you implement the health measures, including having, for example, water and soap at the entrance, ensuring that there's somebody to ensure that as children go out, teachers go out, come back in, they have cleaned their hands. So you have to really to modify classes and rearrange everything and observe the health etiquette being put forward by the Minister of Health. But in my view, if I was the President or Minister of Health, I wouldn't advocate for opening of schools, colleges, and universities and institutions at this stage. Finally, on the state of emergency, Uganda has had states of emergency, and some of them so draconian in the 60s and 70s, even recently, when some parts northern Uganda, I think, was a disaster, when there was famine, even in eastern Uganda. What we need to be careful about, Uganda is among those countries that have a fragile democracy. Institutions and respect of rule of law have not taken root. Under Article 46 of the Constitution, when a state of emergency is declared by an act of parliament, all human rights and freedoms are suspended. So here, at least, there is a partial lockdown. Some of the rights are being respected. You can walk out and go to the supermarket, etc. Under a state of emergency, a government can even come up and declare anything. And I'm getting worried about this when we are approaching elections. I'm sorry to talk about something outside. When we are approaching outside elections next year, You are going, when you have a state of emergency, then you are going to have suppression of rights and freedoms. I leave it at that because it's a bit political. Thank you. Then finally on northern Uganda. Hello?
We can
Hello?
hear you.
Yes, finally, someone asked on northern Uganda. This is a very serious concern. Our constitution and policy framework, they talk about equity. They talk about regional balancing. But this persistent marginalization and vulnerability in northern Uganda and some parts of eastern Uganda must stop. But that one had not brought me here. I'll leave it at that. Thank you.
Thank you very much. We'll now have Professor Sarah.
Hello, can you hear me?
Yes, we can hear you loud and clear.
Okay, thank you very much, Salome. I had a few questions, and one was that I would like to start with has to do with Dunstan. What do I suggest in the event that courts are not hearing? I think that's a difficult one because courts did not say they are not hearing, but they said the emergency that moves court has to be a real emergency. So if a person, and we know most, like for example, most children are abused by those they trust most, by those they know within the family, relatives. Okay, teachers are not now on the scene. So if a child has been abused and is under the control of these parents or these adults, and they choose not to have this matter go, what will that child do? If it was a school system, maybe someone else would have picked it up. So this containment is an issue. We all have to think, particularly civil society organizations that work around this matter. But basically I can support, I know somehow the police has provided some hotlines, but I think one way we can also do something about this is the civil society organizations that work in this field should provide hotlines, you know, like how the led Rose from Sehud provided a hotline. So maybe if UONET, if FEED also provided a hotline, so that the women who are abused, the girls who are abused, even if they are boys, raise a matter of emergency to this hotline, and somehow this CSO can connect them with the police, and then intervention can be done quickly. Otherwise, it's going to be difficult to prove anything after the lockdown. Then Mr. Mulumba asked about how do we get organized, because he said there's a gap. I know this was not directed at me, but there's a gap in CSOs. I think the CSOs, this is the opportunity for them to reorganize and to know that opportunity comes to those who are organized. It's no longer business as usual waiting for which donor has sent out which call. Even we in the academy are doing that now. So it's not which call and then you respond. We have to go back, strategically map our areas of influence and the operation so that if something like this hits, we know exactly who should get there. Then Mr. Semuyaba asked about how the pandemic has increased gender inequality. Already I said gender inequality is historical, it is structural. What the pandemic does, or any kind of crisis does to inequalities, it makes them worse. Let me give you an example. A single mother who has been struggling to provide and was either roasting maize and vending clothes and whatever, now can no longer move. She was already a single mother struggling with challenges of being a single mother. She goes out to sell mangoes, she's beaten. So in addition to being a single mother who cannot feed children, she also has an injury to attend to with no income and maybe no job. That is compounding an inequality. That person ends up worse. If we are to take it to the angle of disability, last week we had a story of Mr. Oloya, who is deaf, dumb, and blind. He had to go out to ease himself because in Alebutongo where he is, they ease themselves outside the house. He landed amongst LDUs who ordered him to stop. He could not stop. He was shot at. His leg has been amputated. So in addition to being deaf, dumb, and blind, he is also now disabled. That's what we mean with crisis, if not well handled, actually compound inequality. If a woman was being battered before in the evening, now she can actually be battered during the day because they are stuck together and they are making each other unhappy. A man who was poor and struggling to carry luggage in Owino so as to put food on the table, now is stuck with not having to provide and with being asked to provide. So this creates the stresses that Professor Segane tried to address. So it may not necessarily cause, but it compounds and makes a bad situation worse. There was a case among those who were remanded to Chitali until the 23rd April. A woman, an elderly woman in a wheelchair who was arrested among those who had violated curfew. So she's old, she's female, she's disabled, and now she's imprisoned. So that's what we mean. There was a question on elitism and over medicalization. What we mean here is through whose lens, through whose viewpoint are these interventions being made? We know COVID is a disease, okay? And as a disease, it is a prerogative of the medical experts. But the responses to COVID, wash your hands, self-distancing, social distancing, we call it, do not touch this, do not touch the other. All these are behavioral matters. So if, however much the medics sing them, but the community experts, the behavioral experts do not come and make people in the community appreciate, why don't you need to hug anymore? Why aren't you shaking hands? People will hear them and put them aside. And I know Salome asked that they don't see these things. People are saying Uganda is prepared for pandemics. They don't. Actually, Uganda has been prepared for pandemics since time immemorial. We are permanently under emergency. And one of the things we perfected is biosecurity, biocontainment. That's why you don't see things breaking out. When Uganda hears there's a suspected case of Ebola, already the emergency teams go in, WHO is informed, CDC is informed, we don't hide info. So we normally contain. So biosecurity and biocontainment, we are very good there. That's why when we say we are prepared and people don't see, it's because they don't see. But the effect of that on the community side is people don't take these things seriously. So you tell people, wash your hands. The public places will put there a tank one day for washing hands. Tomorrow it doesn't have water. You tell people don't hug. They don't see it. They haven't seen anyone die from COVID. So why aren't we hugging? Why aren't we shaking hands? So to institutionalize and normalize and routinize those practices, you need the social scientists to do that because they're the experts of looking at society. Then why do we say elitism? When you say wash your hands, self-distancing, what does that mean to a person who doesn't have water in the house? Because they have to stay at home and yet wash their hands, but water is collected a kilometer away, okay? So can we, for once, stop thinking as we in bungalows with the piped water and also apply a lens of that person in a Muzigo whose water comes from a Mudumu 100 meters away and going to that borehole, or that Mudumu means that she's going to find people there. She cannot tell them, go away, because I have to fetch water and I have to do social distancing. So these things, when I mean elitism, that's what we mean. Whose viewpoint, whose lens are we looking through these things? That also goes hand in hand with the regional marginalization, and which I had forgotten to talk about, the issue of tribe. All the messaging on COVID, at least on my phone, are in English and Luganda. And thank God I can understand Luganda. But is there messaging going out to the other tribes, at least Runyachitara, Luo, and I don't know, Lugisu, whatever, Kupsabin? We need to think about this in a more serious manner. And so there's a lot we can do. I had forgotten about stigma. There's the issue of stigma. Someone talked about HIV. What does HIV mean in all this? It was one of the questions in the chats. I mean, people who were already sick and did not want to be known to be sick in the community. But now if we say the bicycle man is bringing ARVs, what does that mean? Just like the bicycle man not coming, what does that mean? But also now we are having stigma where people think it is only the sex workers who are bringing the disease, because the sex work, since now the disease is with the truck drivers and the sex workers are going to truck drivers, so the sex workers are the problem, and soon the disease is going to have a female identity, or the bearer of the disease will be a female. I think this is something we need to pay attention to. Then, of course, sexual favor is another. Traditionally, women are sexualized, and now they have a basic need of food. You give me sex before I give you food. That's compounding inequality. Just one last one on one of the things we can do with regard to decongesting. We have to do, I think, online learning for urban areas, but for rural areas, we really need to think. And also an opportunity, you know, these opportunities which are coming up, we are seeing traders are being talked about. You know, COVID has brought opportunity for boo-boo. Can we have these women with the sewing machines actually sew these things? so that they also get to benefit.
Professor.
Yeah. Thank you very much. Let's leave it at that.
What has happened now?
Hello, I thought I was told to stop, so I stopped.
Continue and complete your point, Prof.
No, I was saying that the last point was with regard to COVID providing an opportunity that also should be gendered so that even the women, the poor get to benefit from those opportunities. For example, simple things like masks, they can make them, they can sew them. So let us also factor in the disadvantaged in the advantages that COVID has brought. And that was my last point. Thank you.
Thank you. Thank you very much, Professor, for really expounding gender beyond sex and beyond the gender roles. So concluding remarks from Professor Waiswa, and then lastly, Professor Segane, and we bring this to an end.
Thank you so much. I'll answer a few questions. There was a question whether abortion has increased. We don't have data yet, but I'm glad I'm on a team which is actually going to be starting monitoring the data in terms of what is happening in the country in terms of health systems. At the end of this month, actually, we should be having our first report. Resources are still being mobilized, but we have begun some work. Women are trying to give birth because they will give birth to those who will be infected. The Minister of Health then in terms of nutrition, very much. I think the biggest public emergency we have in nutrition or malnutrition. When 1 out of 3 kids in our country are started, that is, I call it a chronic emergency, a chronic public health emergency. Because if it or malnutrition, your human is affected. Your environment will never be more. And that means we have
Professor Waiswa, we can't hear you well. Are you there? Let's move to Professor Segane as your network is being reconnected.
Hello, did you lose me?
Yes, we had lost you. Your network is jumping.
Sorry about that. Blame MTN. What did you hear last? Solomon?
That you're going to do a national survey.
Okay, we are going to, there's a national survey. I'm saying that we've started a system for monitoring the health system in Uganda, especially with reference to reproductive, maternal, newborn, child health and nutrition. And we'll be giving actually regular information to the Ministry of Health so that they can improve their responses. And then I was saying that on nutrition for me is my biggest concern in the country. I call it the #1 public health emergency we have, because 1 in 3 of our kids are stunted. And when you have a stunted child, it means that the brain is also stunted. And then if you add these pandemics, they make the situation worse. Such children will never be as clever as they should and will never be as productive. But this is not good for Uganda, and the numbers are increasing. So I think this is an area I would like to call people upon, that we should move actually to declare malnutrition a public health emergency, so that due attention is given to it. Is Uganda prepared for epidemics? Yes and no. When COVID came, Uganda was actually, in terms of surveillance system, was one of the most prepared countries in the world. We already had a surveillance system at the borders, but also the Ministry of Health has actually a center which monitors the whole country in real time, with almost 30 people working full time online and monitoring what is going on, and the system for data collection. But I think it is the response where we have a big problem, and we need to improve that. Can we track what is happening? I think I've commented on that. On elitism, Salah's good justice it. I just want to add, for me, elitism is when we have a health system or a response or a management system that is only in the eyes of those who are school. Most of the problems affect people around. Then CSOs, I think it is a big opportunity for CSOs to reorganize themselves, to get more coordinated, and to become more relevant. And then my last closing point, I think COVID is a big wake-up call for us, and it has spared us, and I hope we use the opportunity so that we learn that we need to be more organized, to have better housing, have storage systems, be more self-reliant, and be able to do most of the best things within the country. But
Professor Waiswa, are you there?
This, since my network is also, I was saying that COVID is a big wake-up call, which the lesson given us, and be able to build a more resilient national system within the health system trained and self-reliant, and look at healthcare as a real a productive sector. We are not okay in terms of health. We cannot be okay in terms of as a country. Thank you so much for the opportunity.
Thank you very much, Professor Waiswa. Lastly, let's have Professor Segane and then bring this webinar to an end. Professor Segane.
Hello, hello.
Yes, we can hear you.
Okay. I was saying that I'm going to answer a few questions put to me, and then I'll give my concluding remark. First, there was something about stigma, I think by Rosemary. And the best way to handle this is to handle the pandemic holistically. To do that, we certainly need a national psychosocial team or response, which will handle all that goes with behaviorisms of both individuals and the community towards the pandemic. The next question was asked by someone about involving, I think, that UNICEF had put up a national response in rural areas. UNICEF itself deals mainly with children, and it's not really a national response team. We are talking about major mental health problems coming out of the pandemic, like post-traumatic stress disorder, like depression, substance abuse, suicides, domestic violence, care of the mentally ill, not wanting to restrict ourselves to only children, and wanting to be quite broad-based. That can best be handled by a national psychosocial response team. Then Mrs. Mulumba talked about civil society. How can civil society help? And I think he quoted Sawa Kirianga, who said that we need a coordination mechanism. All that can only be provided by a national psychosocial response team. Usually they tend to be the coordinators of responses in emergencies. Salome, our team, talked about disaster preparedness and wondering whether we are really prepared for disasters. We have handled a few disasters, but none of them have we had national psychosocial response team. The only attempt was with Northern Uganda post-conflict, when we talked about Nupsana, led by the late Dr. Mungerera. That was something near to that. Otherwise, we have just had individuals and individual organizations trying to tackle some of these things. But we have had certain epidemics in the past, cholera, and I think also Ebola, but not to a very big extent. Although in public health, we say that the occurrence of one rare disorder itself makes an epidemic. Now, appreciating mental health in our daily lives. This is a struggle which we have as mental health workers, increasing mental health literacy, not only in the community, but also in health workers, and especially policymakers, and not making it a joke or something to laugh at, and which has been the problem with us trying to get government, parliament, and others to try to include and always integrate mental health in whatever measures of intervention that they're considering. Otherwise, we live with mental health or mental illnesses or mental problems every day of our lives, in all our lives, and in all families. Then there was a speaker who talked about, never say his name, who talked about how do we set up a national psychosocial response team. And the most important thing is to be aware that we need it. And we're beginning to talk about it, and I think Shehud should take it up, as well as other NGOs, to begin to talk about this thing more loudly, so that it becomes something that policymakers begin to think about, and something which the Ministry of Health can take seriously. And it is one of the things that we said we should be recommending to our Ministry of Health, and certainly in the response to this pandemic. Then Zarwango talked about police officers. Police officers are frontline workers. All law enforcement agents are frontline workers, along with healthcare professionals. These are the people I talked about who need debriefing and PPE, or personal protective equipment. And in fact, some of them have been infected. I think you've heard about the case in Masindi on the news, and also the one in Jinja. So they're already very stressed, they're worried, they're anxious, and they realize that they're dealing with an epidemic which will involve their very lives. So they need to be involved, and the psychosocial response team can begin to help out. And then another speaker, or rather participant, asked about how do we help the traumatized at community level. This is when we talked about going out, setting up the psychosocial response team, and going out to the regional referral hospitals and community centers to train responders there who should be able to help, and setting up crisis helplines and mental health intervention teams or crisis teams at all health centers. These are things that we need to take seriously in this response, and also permanently in our Ministry of Health, including dealing with such allegations as that anonymous participant said of sexual favors. If there's a crisis hotline, they should be able to call and report, sexual abuse or exploitation at those ones, so that appropriate measures can be taken. Again, to emphasize, setting up a psychosocial response team deals with those things like elitism, discrimination, in helping in the national response. Now, as a concluding remark, I'd like to remind everybody of something that they're seeing but are not quite aware of. We have not had any COVID-19 deaths in this country. but we already have had deaths related to the COVID-19 epidemic. There have been suicides, there have been homicides, people have died of drinking or themselves to death in different places. We have had deaths, for example, in Jinja, due to injuries, including even the RDC, who was there, and you saw it in the news. So these are already deaths in the COVID-19 epidemic. We do not have to have it to be infective for it to cause death. So we should already be alarmed that things are happening, although they're not necessarily related to being infected. But if we're in the business of preserving life, these should be things that we should have foreseen and been able to prevent. All of these injuries have come in the wake of the COVID-19 pandemic. And that's why we say that a psychosocial response team is of necessity in this pandemic. Thank you very much.
Thank you very much, Professor Segane, for your concluding remarks. I'd like to bring this webinar to a close. First of all, by challenging us that COVID-19 is here with us. It will have tremendous impact on so many things, on how we live our lives, on our incomes, on our priorities, on the dominant narrative in terms of global development, on the sustainable development goals, on the rights that we pursue for ourselves and others, as well as on the conversations that we next few years or even a whole lifetime. It means that this being one of the big health crises in the past decade, we need to reorient ourselves. We need to realize, we need to bring health, other than always assuming that political, civic, and economic, social, and cultural rights. We need to go back to the basics. What does that mean? It means we need to get away from our comfort zones. We need to learn more, because they say we learn more in crisis than in comfort. We are in crisis as a global community. So we need to allow ourselves to learn from that. I'd like to conclude by thanking keynote speaker, Professor, thanking our panelists, Professor Peter Waiswa, Professor, you'll have to acknowledge they really stretched our imagination. As you thought you knew about COVID in this aspect, there's something else you're thinking, so that is what it means. That then takes us, how are we going to continue then? We have a hashtag, and our hashtag is on the screen. Is it there? We have a hashtag which is going to make sure that we continue to have this conversation. The hashtag is COVID and human rights, or SRHR, or you can visit the website www.jasprogramme.ug. Let's continue having the conversations, because the more we have conversations with each other, the more we clarify things, but also the more we allow ourselves, even if we do not have it okay. I'd like to end by thanking the conveners of this webinar. Thank you, JAS Program partners, Akina Mama Africa, Human Rights Awareness and Promotion Forum, HEPTANDA, Napofano, Rahu, UNESCO, and SEHAD. Thanks for such a great program. And then also, I'd like to thank the Swedish International Development Cooperation Agency, SIDA in Uganda, for supporting this particular conversation. The JAS program is a 3-year program where health and human rights, especially SRHR, are going to be part of our menu, part of the conversations, but also allowing us to walk the journey together. Thank you very, very much. For your information, the JAS website has the papers that have been presented. These are papers that actually are broader than the time would allow us to have a conversation, and the panelists really put their best in those papers. Please visit the papers, expand your knowledge, because we are at a point in time where we need to move away from what we're comfortable with to get into the new normal. With that, I'd like to thank you all. In terms of the next steps, there's going to be an audio recordings, there's going to be a webinar report, But also, you can still continue visiting the JAS website and getting more information, as well as the Facebook and Twitter handles of CEHAD. Thank you very much, and I sign out. And for our participants, you really, really, really were a great team. Thank you.
Thank you. Bye.